Alo. Alo, 1, 2, 3, 4, 5, 6. Alo, alo.
Tiếng Việt nghe hả?
Kính thưa quý vị đại biểu, thưa quý thầy cô, chỉ còn ít phút nữa là chương trình hội thảo về cẩm nang chuyên gia trong lĩnh vực y học gia đình và cấp cứu sẽ chuẩn bị được bắt đầu. Xin được trân trọng kính mời quý vị đại biểu, quý thầy cô cùng ổn định vị trí.
In just a few minutes, the post of experts in family medicine and emergency medicine will officially begin. We would like to invite all delegates, all lecturers and colleagues from Phạm Ngọc Thạch University of Medicine and other workplaces to settle down in your positions. Thank you very much.
Xin hân hoan chào đón quý vị đại biểu, quý cô, quý thầy đã cùng về tham dự chương trình hội thảo ngày hôm nay với chủ đề cẩm nang chuyên gia trong lĩnh vực y học gia đình và cấp cứu được tổ chức bởi trường Đại học Y khoa Phạm Ngọc Thạch cùng tổ chức Học Mãi.
We are pleased to welcome all the distinguished delegates and guests to attend the Pros of Experts in Family Medicine and Emergency Medicine seminar. This seminar is organized by the collaboration between Phạm Ngọc Thạch University of Medicine and Học Mãi Foundation.
Lời đầu tiên, thay mặt cho trường Đại học Y khoa Phạm Ngọc Thạch và tổ chức Học Mãi, ban tổ chức xin gửi lời chào nồng nhiệt và trân trọng đến tất cả quý vị đại biểu, quý cô thầy đã cùng về tham dự chương trình ngày hôm nay.
First of all, on behalf of Phạm Ngọc Thạch University of Medicine, Học Mãi Foundation and the seminar organizer, I would like to thank you with the warmest and sincerest regards.
Kính thưa quý vị đại biểu, thưa quý cô thầy cùng quý đồng nghiệp, sau đây tôi xin thông qua chương trình làm việc của hội thảo sẽ gồm các hoạt động sau đây.
Dear delegates and distinguished guests, the seminar agenda includes the main activities.
Thứ nhất, tuyên bố lý do giới thiệu đại biểu. Thứ hai, phát biểu khai mạc và phát biểu chào mừng. Thứ ba, các báo cáo khoa học sẽ diễn ra trong hai phần. Phần thứ nhất đó là về y học gia đình và chăm sóc sức khỏe ban đầu. Phần thứ hai đó là cấp cứu. Và cuối cùng đó là phát biểu đáp từ và bế mạc hội thảo.
First, statement of reasons and delegates introduction. Second, opening and welcoming speech. Third, scientific reports through two sessions. Session number 1, family and primary care. And session number 2, emergency medicine. And finally, the closing speech.
Kính thưa quý vị đại biểu, thưa quý cô thầy cùng quý đồng nghiệp, y học gia đình và cấp cứu là hai lĩnh vực đóng vai trò quan trọng và thiết yếu trong hệ thống chăm sóc sức khỏe. Vì vậy, việc thường xuyên được cập nhật kiến thức trong các chuyên khoa này là rất quan trọng. Hiểu được nhu cầu này, trường Đại học Y khoa Phạm Ngọc Thạch phối hợp cùng tổ chức Học Mãi đã tổ chức hội thảo đào tạo y khoa liên tục nhằm nâng cao các kiến thức trong lĩnh vực y học gia đình và cấp cứu, cũng như giúp cho các bác sĩ tại Việt Nam nói chung và thành phố Hồ Chí Minh nói riêng có thể học hỏi được các kinh nghiệm từ các chuyên gia đến từ tổ chức Học Mãi và các chuyên gia đến từ Úc, và đó cũng chính là lý do của chương trình hội thảo ngày hôm nay.
Dear delegates, lecturers and colleagues, family medicine and emergency medicine always play an important role in healthcare system. Therefore, regulating updated knowledge of these specialties is very important. Understand this need, Phạm Ngọc Thạch University of Medicine and Học Mãi Foundation have coordinated to organize the continued medical education seminar aiming to improve the knowledge of family medicine and emergency medicine, as well as assist doctors in Vietnam to learn from the experience from the Australian experts. That is the reason for today's programs.
Kính thưa quý vị đại biểu, thưa quý cô thầy cùng quý đồng nghiệp đến tham dự chương trình hội thảo ngày hôm nay, ban tổ chức vinh dự được đón tiếp và xin trân trọng giới thiệu sự tham dự của quý thầy cô, quý đại biểu. Về phía tổ chức Học Mãi xin được trân trọng giới thiệu thầy phó giáo sư tiến sĩ bác sĩ Christopher Pokomy, chủ tịch tổ chức Học Mãi.
Dear delegates, we would like to introduce the guests and delegates today we have in our seminar. On Học Mãi Foundation, I would like to introduce Associate Professor Dr. Christopher Pokomy, Chair of Học Mãi Foundation.
Xin được trân trọng giới thiệu phó giáo sư tiến sĩ bác sĩ Anthony Philip Joseph đến từ khoa Y Đại học Sydney, Úc.
I would like to introduce Associate Professor Dr. Anthony Philip Joseph, Faculty of Medicine, University of Sydney.
Xin được trân trọng giới thiệu sự tham dự của phó giáo sư tiến sĩ bác sĩ Sally Ann McCarthy, bác sĩ cấp cứu cấp cao tại bệnh viện Prince of Wales, Úc.
would like to introduce Associate Professor Dr. Sally Ann McCarthy, Senior Emergency Physician of Prince of Wales Hospital, Sydney, Australia.
Xin được trân trọng giới thiệu sự tham dự của bác sĩ Warwick John, là giám đốc lâm sàng mạng lưới bác sĩ gia đình Úc.
I would like to introduce Dr. Warwick John, Director of Portuguese, Australia.
Xin được trân trọng giới thiệu sự tham dự của ông Đoàn Đình Mạnh Toàn, là đồng sáng lập và giám đốc điều hành của quỹ ASIF.
I would like to introduce Mr. Đoàn Đình Mạnh Toàn, co-founder, CEO of ASIF Foundation.
Xin được trân trọng giới thiệu sự tham dự của cô Liz Chemist, là thành viên của tổ chức học mãi.
I would like to introduce Dr. Liz Chemist, member of Học Mãi Foundation.
Và xin được trân trọng giới thiệu sự tham dự của cô Elizabeth Brown, là thành viên của tổ chức học mãi.
And finally, I would like to introduce Dr. Elizabeth Brown, member of Học Mãi Foundation.
Về phía các khách mời của trường Đại học Y khoa Phạm Ngọc Thạch, xin được trân trọng giới thiệu sự tham dự của thầy tiến sĩ bác sĩ Lê Trường Giang, Chủ tịch Hội Y tế Công cộng Thành phố Hồ Chí Minh.
On Phạm Ngọc Thạch University of Medicine side, I would respectfully introduce Dr. Lê Trường Giang, Chair of Public Health Association of Ho Chi Minh City.
Xin được trân trọng giới thiệu sự tham dự của thầy Phó Giáo sư Tiến sĩ Bác sĩ Nguyễn Thanh Hiep, Hiệu trưởng trường Đại học Y khoa Phạm Ngọc Thạch.
I would like to introduce Associate Professor Dr. Nguyễn Thanh Hiep, Rector of Phạm Ngọc Thạch University.
Xin được trân trọng giới thiệu sự tham dự của cô Phó Giáo sư Tiến sĩ Bác sĩ Trần Thị Mộng Hiệp, là cố vấn chuyên môn kỹ thuật của Phòng khám đa khoa trường Đại học Y khoa Phạm Ngọc Thạch.
I would like to introduce Associate Professor Dr. Trần Thị Mộng Hiệp, Clinical Technical Consultant of the Polyclinic.
Xin được trân trọng giới thiệu sự tham dự của tiến sĩ bác sĩ Võ Thành Liêm, Phó trưởng Bộ môn Y học gia đình trường Đại học Y khoa Phạm Ngọc Thạch.
I would like to introduce Dr. Võ Thành Liêm, the Deputy Head of Family Medicine Department.
Và cùng tham dự là báo cáo viên cho chương trình hội nghị ngày hôm nay, xin được trân trọng giới thiệu Thạc sĩ bác sĩ Trần Thị Hoa Vi, giảng viên Bộ môn Y học gia đình.
And I would like to introduce today's speaker, Dr. Trần Thị Hoa Vi, Lecturer of Family Medicine Department.
Trân trọng giới thiệu tiến sĩ bác sĩ Trần Đức Sĩ, là giảng viên Bộ môn Y học gia đình.
I would like to introduce Dr. Trần Đức Sĩ, Lecturer of Family Medicine Department.
Trân trọng giới thiệu sự tham dự của thầy Thạc sĩ bác sĩ Nguyễn Hồng Trường, là giảng viên Bộ môn Hồi sức cấp cứu chống độc.
I would like to introduce Dr. Nguyễn Hồng Trường, Lecturer of Emergency and Antitoxic Department.
Kính thưa quý vị đại biểu, và để bắt đầu chương trình hội thảo sáng ngày hôm nay, ban tổ chức xin được vinh dự và trân trọng giới thiệu sự tham dự và sẽ phát biểu khai mạc cho chương trình ngày hôm nay. Trân trọng giới thiệu thầy Phó Giáo sư Tiến sĩ Bác sĩ Nguyễn Thanh Hiep, Hiệu trưởng trường Đại học Y khoa Phạm Ngọc Thạch. Xin được trân trọng kính mời thầy.
Ladies and gentlemen, to start the program without making you wait any longer, we would like to respectfully invite to the stage Associate Professor Dr. Nguyễn Thanh Hiep, Rector of Phạm Ngọc Thạch University of Medicine, to make the opening speech. Please welcome.
Good morning. Let me speak with our team, and Dr. V explain in English for you. Kính thưa thầy Giang, kính thưa các cô các thầy, đặc biệt là các giáo sư đến từ Úc, quỹ Học Mãi Foundation. Hôm nay thì trường Đại học Y khoa Thạch lại có rất là nhiều cái sự kiện quan trọng diễn ra đồng thời. Một cái sự kiện đó là ngày hôm nay cái hội nghị y học gia đình, và có lĩnh vực của cấp cứu cùng tham dự.
Dear delegates, Dr. Giang and doctors from Học Mãi board members, today in Phạm Ngọc Thạch University of Medicine, we have various events that are organizing in our school. Especially this seminar is about the medical education, the family medicine education and emergency medicine.
Mới vừa ngày hôm qua thôi, buổi chiều ngày hôm qua, trường Đại học Y khoa Thạch và thầy tiến sĩ Lê Trường Giang tổ chức một cái hội thảo tọa đàm trao đổi cực kỳ quan trọng đó là phát triển y tế cơ sở, trong đó là có vai trò của bác sĩ gia đình.
So yesterday, our school and Dr. Lê Trường Giang had held a seminar. It's very important about improve the basement medical in Vietnam, which emergency medicine plays a very important role.
Và cái hội thảo ngày hôm nay thì đến từ một cái cơ duyên, đó là nghiên cứu sinh thạc sĩ Hoa Vi kết nối với lại CEO của Học Mãi Foundation.
And to organize today's seminar, we have a chance, a lucky chance, that Dr. Trần Thị Hoa Vi has cooperated with the CEO of Assoc, Mr. Toàn, to organize today's seminar.
Và trường thì rất là may mắn đã đồng hành với lại tổ chức Học Mãi qua nhiều cái chương trình học bổng và những cái đợt thực tập của sinh viên của trường tại Úc.
The Phạm Ngọc Thạch University of Medicine is really lucky that have various chance to cooperate with your foundation, to have your cooperation have sponsored our students to have the scholarship in Australia as well as to practice in Australia.
Và tôi cũng được biết là cái đợt này thì các giáo sư cũng có tuyển chọn các ứng viên để tiếp tục cho những cái học bổng, những cơ hội để học tập ở bên Úc.
And as far as I know, this time the Học Mãi Foundation also have a fellowship for our students and also for doctors in Vietnam.
Thay mặt nhà trường, chúng tôi vô cùng tri ân các giáo sư của Úc đã đồng hành với lại nhà trường, và đặc biệt là có mặt để tổ chức một cái hội thảo hết sức là quan trọng ngày hôm nay.
And I would like to appreciate all of your effort that call all of your time to collaborate with our university and be here today with the seminar.
Y học gia đình ở Việt Nam thì vẫn còn đang trên đà phát triển. Nói chung là còn rất là nhiều cái yếu tố để mà có thể phát triển đúng như là cái nguyên lý cũng như là cái mong muốn của người dân.
And the family medicine in Vietnam is on the way of their growing, and we are trying to grow as to meet our standard requirements and for the needs of our citizen in Vietnam.
Thì trường Đại học Y khoa Thạch có cái phòng khám đa khoa hoạt động theo nguyên lý học gia đình.
And in Phạm Ngọc Thạch University of Medicine, we have a polyclinic that run based on the family medicine philosophy.
Và thông qua cái mô hình này, chúng tôi mong muốn là có sự hỗ trợ của các giáo sư Úc và các chuyên gia để có những cái hoạt động về đào tạo, huấn luyện và đặc biệt là nghiên cứu để phát triển mô hình này ở thành phố Hồ Chí Minh cũng như Việt Nam.
And through this model of practice, we would like to help your assist, your help to improve this model, the practice in Ho Chi Minh City as well as in Vietnam.
Và một lần nữa thì tôi hết sức xin lỗi, bởi vì bản thân cũng là trưởng bộ môn học gia đình, nhưng mà có một cái hội thảo cũng phải tham dự với lại các giáo sư của các trường đại học ở Đài Loan, Úc và Đài Loan, Nhật và của Hội kỹ thuật hình ảnh của Việt Nam. Thành ra rất là tiếc khi không có thể tham dự suốt, nhưng mà những cái bài báo cáo những nghiên cứu và sẽ trao đổi cùng các giáo sư để có những cái chương trình dự án hợp tác trong cái giai đoạn tiếp theo.
And I'm very sorry that as the head of the family medicine department, I should be here all day with all of the seminar with you. But as you can see, we have another seminar is about the imaging technical. So I need to run over there. So I'm so sorry for not being here with you all along. But I hope that we have further collaboration in the future.
So thank you so much.
So thank you.
Cảm ơn các cô, các thầy, các đại biểu.
Xin được trân trọng cảm ơn phần phát biểu của thầy Phó Giáo sư Tiến sĩ Bác sĩ Nguyễn Thanh Hiệp, Hiệu trưởng Trường Đại học Y khoa Phạm Ngọc Thạch.
We sincerely thank the speech of Dr. Nguyễn Hiep, the Rector of Phạm Ngọc Thạch University of Medicine.
Và tiếp theo sau đây xin được trân trọng kính mời quý vị đại biểu, quý cô thầy cùng đến với phần phát biểu đến từ đại diện của tổ chức học mãi. Xin được trân trọng kính mời tiến lên sân khấu Phó giáo sư tiến sĩ Christopher Stephen Pokomy, Chủ tịch tổ chức học mãi sẽ có đôi lời phát biểu. Xin được trân trọng kính mời.
And to continue the event, we will listen to the sharing from the representative of Học Mãi Foundation. I would like to invite Associate Professor Dr. Christopher Stephen Pokomy, Chair of Học Mãi Foundation, to give a speech. Please welcome.
Cảm ơn. Distinguished colleagues and friends, on behalf of Học Mãi, I would like to thank you for inviting us to the Chung Dai Hop Pham Ngọc Thạch. This is our first time here, and we hope it's not the last. This seminar has been, or the topics for this seminar have been chosen, as you know, because we think that these are areas that are very important to Vietnam, family medicine in particular and emergency medicine. To put this seminar together takes a lot of work, and I'd like to thank a few people, particularly Toan Doan, who's been instrumental in putting this seminar together. So thank you, Tone. And Tone, as you know, has an organisation or foundation, the Australian Social Impact Foundation, which has contributed enormously, and we thank you, Toan. I'd also like to thank our speakers, Professors Sally McCarthy, Tony Joseph, and Warwick Young, who've also put in a big effort to make this a success. As we always say in Học Mãi, we don't come here to teach you, we learn from each other. And Học Mãi is now in its 26th year, and hopefully will continue for many years to come. And we hope to come back to Ho Chi Minh City next year, and also many years in the future. So thank you, and I hope you all enjoyed today's seminar. Thank you.
Thank you so much. So you will stay in the for the souvenir.
For the pictures.
Okay.
Kính thưa quý vị đại biểu, thưa quý cô thầy, và để cảm ơn sự hiện diện của quý vị đại biểu, quý thầy cô, đặc biệt là các vị khách, các thầy cô đến từ tổ chức Học Mãi Úc. Ngay sau đây xin được trân trọng kính mời quý thầy cô sẽ cùng tiến lên sân khấu và nhận những phần quà lưu niệm đến từ trường Đại học Y khoa Phạm Ngọc Thạch, cũng như có một bức ảnh lưu niệm cho chương trình sáng ngày hôm nay.
I would like to sincerely thank Associate Professor Dr. Christopher Stephen Pokomy, Chair of Học Mãi Foundation, for your speech, and for the appreciation toward the presence of all our guests today. I would like all lecturers and guests from Phạm Ngọc Thạch University of Medicine and Học Mãi Foundation to come to the stage to have the gifts and take pictures.
Dạ, em xin mời quý thầy cô đến từ tổ chức Học Mãi. Xin mời thầy Giang, dạ, em mời cô Mộng Hiệp, em mời chị Hoa Vi, em mời thầy Trường, dạ. Và đại diện cho trường Đại học Y khoa Phạm Ngọc Thạch, thầy Nguyễn Thanh Hiệp, hiệu trưởng sẽ có những phần quà gửi đến quý thầy cô của tổ chức Học Mãi. Xin được trân trọng kính mời thầy ạ. Dạ. Dạ. Em mời thầy Hiệp sẽ trao quà. Dạ, dạ, các bạn.
Chị biết không? We would appreciate your applause to the board.
Dạ, xin được trân trọng kính mời hội trường hãy dành một tràng pháo tay để chúc mừng chương trình hội nghị sáng ngày hôm nay ạ. Dạ. Xin được trân trọng cảm ơn quý vị đại biểu, quý cô thầy ạ. Dạ.
Thank you so much, delegators and guests.
Dạ, chào sư.
Chắc là anh sẽ chưa mời thầy Hiep đến, mình chỉ phải bắt đầu.
Dạ. You welcome. Kính thưa quý vị đại biểu, thưa quý cô thầy, và để bắt đầu chương trình sáng ngày hôm nay, chúng ta sẽ đến ngay với các nội dung tại phiên hội thảo ở phiên báo cáo thứ nhất về chủ đề y học gia đình và chăm sóc ban đầu.
Dear delegators and distinguished guests, right now we will come to the first session of today's seminar with the topic Family Medicine and Primary Care. We sincerely invite.
Rất mong rằng những thông tin sẽ được cung cấp trình bày bởi các báo cáo viên sẽ là một nội dung hữu ích cho quý vị đại biểu, quý thầy cô trong công tác thực hành của mình.
We hope that today information will present by our presenters will bring you the practical information that can be applied to the professional career.
Và ngay sau đây xin được trân trọng kính mời phần điều hành của cô Phó Giáo sư Tiến sĩ Bác sĩ Trần Thị Mộng Hiệp và Phó Giáo sư Tiến sĩ Bác sĩ Christopher Pokomy.
And we would like to invite Associate Professor Dr. Christopher Stephen Pokomy and Associate Professor Dr. Trần Thị Mộng Hiệp to chair the seminar.
Xin được gửi lời kính chúc thành công đến chương trình hội nghị sáng ngày hôm nay và kính chúc cho chúng ta sẽ có một buổi thật là bổ ích.
And I hope that this seminar will be successful.
Dạ, em mời cô Hiệp. Dạ.
Dear Professor Christopher Pokomy, dear Professor Trần Thị Mộng Hiệp, dear Professor Nguyễn Trường Giang, and today I'm Dr. Trần Thị Hà Vi. I'm a lecturer of Family Medicine Department, and I'm responsible for the training and research scientific research units in Polyclinic of Phạm Ngọc Thạch University of Medicine. And today I'm honored to present the topic about continuing medical education and improve competency of family medicine doctors in Vietnam. Before I present my topic, I would like to say some Vietnamese for my authors in this homes. Xin chào các anh chị học viên cũng như là quý đồng nghiệp đã có sự quan tâm đến chương trình học mãi, thì các anh chị có thể đeo tai nghe để dịch qua tiếng Anh. Tại vì trong hội trường ngày hôm nay mình sẽ nói bằng tiếng Anh và có cabin phiên dịch qua tiếng Việt cho các anh chị trực tiếp. Dạ, xin cảm ơn. And I would like to present my topic. And first of all, I would like to talk about the context of health system in Vietnam. This is a pyramid shape from bottom to top. You can see in my slide the first level, primary healthcare units and district hospital, and then the second level is the city hospitals, and the third level the central hospitals. And this diagram performs the way the general Vietnamese inhabitants approaching to the health system. This is the true way. If the Vietnamese people have any problem of their health, they must go to the primary care network, such as the primary healthcare units and district hospitals. And then, if over the capacity of the doctor at primary care network, they can transfer to city hospital and then change to central hospital. But you see, in the real way in Vietnam now, despite of this organization, tertiary hospitals are overwhelmed by the lack of effective of the frontline healthcare system and the earlier choice of dividing prevention and curative care. And this has a significant impact on the early diagnosis, management modalities, and follow-up and management of patients of own disease. And I would like to talk about the family medicine principles because it's very, very important to practice family medicine in Vietnam, develop or organize any CME program for train for doctor families in Vietnam. There are 6 family medicine principles. The first is first contact comprehensive healthcare. The second is continuous healthcare. And the third is coordinated healthcare. The fourth, family-centered care. And the fifth, very, very important, preventive care. And the sixth is community-oriented care. And based on 6 family medicine principles, it can make the strength of family doctors. Family doctor can make the direct access with the patients and their families, and they can make the intervention in the context of their life, and they can create the long-term relationships with patients and the patient's families, and they can detect early disease. They can detect the disease in the early stage, and family doctor can make the trusting relationship with the patients. Yes, it's very important. And good solution of standardization of medical knowledge and clinical skill can develop the professional primary healthcare staff, and then can develop the strength of family doctors. And besides, I would like to talk about how to build the network of family doctors. It needs the main 3 factors. The first is the law, the second is the social insurance, and the third is the training. And the government have the policy to balance the interests of society, people, and family doctors. And the topic today, we focus to the training for family doctor, especially CME, continuous medical education for family doctor in Vietnam. And family medicine training have formal training and continuous medical education. In our university, PNTU University, the formal training, we have medical students. The 5th academic year is approximately around 800 to 1,000 students per academic year. And the postgraduate students, we consider K1, we train from 10 to 25 students per year, and master degree of family medicine, we train from 3 to 6 students per year. And talking about continuous medical education, our department has some course with the meaningful for the practical of for the practice of family doctors, such as family medicine knowledge enhancement. This course lasts for 3 months, and other skills such as electrocardiogram interpretation, chest X-ray interpretation, and such as short course comprehensive management of our patients with diabetes and thyroid disorders. We organize the local and international scientific conference and workshop for family medicine. And we have a question that how can we develop and organize effective CME training for family doctors in Vietnam in general and in our university in particular? We also based on the family medicine principles, and we develop and organize the CME program which are customized, which have interdisciplinary approach and society responsive training. And we also have flexible learning arrangements to meet the requirement of learners' needs, such as we can organize by on-site or in person, virtual, online, and we can use the learning material system of our department to organize the CME course. And also we have to, besides we have to base on the rank order of common office visits of diagnosis, the rank order of chronic condition. We base on that to choose the topic, the subject. We will develop and organize the CME course, which is society is responsive. Yes. And you can see here there are some such as some chronic condition such as hypertension, arthritis, hyperlipidemia, diabetes, depression, obesity, cancer, asthma, and chronic obstructive pulmonary disease, and etc. So we based on that to organize the CME program for family doctor in Vietnam. And this track shows the capacity of CME training of family medicine department at PNTU for treatment 2022 to 2024. And you can see on the track, the orange column, you can see this is the family medicine course. It lasts for 3 months. And from 2022 to 2024, we organize over 400 doctors who participated in family medicine course. Yes, and the blue column you can see here. This is the number of the doctors participated in other subjects of CME course in our department, such as ECG interpretation, or chest X-rays. The course about comprehensive management of patients with diabetes and thyroid disorders. And we also organize the course about mental illness of our patient consultation, the diabetic nephropathy in elderly patients, scientific conference and workshop at local and international. And I show an successful course on our department. This is about comprehensive management of patients with diabetes and thyroid disorder. And you know, based on the family medicine principles, we have to organize with the interdisciplinary approach. So we invite Professor Association Professor Nguyen and Professor PhD Dr. Nguyễn Thị Thu Thảo. She the famous specialist in endocrinology, and Professor Hun Nguyễn Khoản Trang. He is a specialist in obstetrics and gynecology. And they combine with the family doctor, Dr. Lê Đình Phương from FV Hospital. he is the leader, the head of family medicine and internal medicine in FV Hospital, and I at our department in my university to coordinate to organize a course about comprehensive management of patients with diabetes and thyroid disorder. You can see this team is certificate for 48 hours for doctors who participated in this course. And you can see the content is based on the family medicine principle, interdisciplinary to the aim of this course to improve the skill of general doctor, of family doctor in Vietnam, so they can confident to management the patient with diabetes in outpatient. Yeah. Such as you can see the content, update on diagnosis of treatment diabetes. We talk about drug combination. We talk about hypoglycemia. Talk about management of patient with diabetic kidney and prevention, the progress of diabetic kidney. We also focus to pregnancy diabetes management, and another problem is very important is smoking, a major problem in diabetes patient and solutions. And we have the contents about management of lipid disorders in diabetes patient, how management of patient primary and secondary prevention of cardiovascular disease in diabetic patient. And we also the content about mental health care in diabetic patients, talking about nutrition and exercise in diabetes treatment. And the last lesson, we talk about the comprehensive management of diabetic outpatient based on the family medicine principles. And you can see this is the content we developed for course based on family medicine, and this course very successful. You can see the number of doctors participate in this course. The first lesson of Professor Nguyen over 8,000 views for this lesson by online and by on site at the same time. Yeah, and the PhD Dr. Nguyen Thi Thu Thảo over 7,000 views, and Dr. Lê Đình Phương over 1,000 views. And I talk about the comprehensive management of our patient over 7,000 views. And this course have a significant and meaningful have a significant meaning to improve the skill of family doctor, of general doctor in Vietnam to management the diabetic in outpatient. And this is Dr. Hun Nguyễn Khánh Trang for this talk too by directly. And I would like to say about the training session. Dr. Nguyễn Hồng Trường, he will have the present today. You see, this is the training session organized in the COVID-19 pandemic. We organize in the evening, and we talk about oxygen therapy, early detection, and appropriate treatment for severe symptoms of COVID-19. And at that time, there are over 500 participants for this training session. Yes. And this is another conference we cooperate with Home Health Operation and CDC to organize. To organize the conference about the home-based care for COVID-19 patients and COVID-19 prevention and control in the community. And at that time, over 5,000 participants online and nearly 2,800 CME certificates were provided free from Phạm Ngọc Thạch University of Medicine for all doctors in all over province in Vietnam. And I would like to talk about the strength, the weakness, the opportunity, and the threat of continuing medical education for family doctor in Vietnam and in our university too. Talking about the strength, we have the staff of young, dynamic, enthusiastic lecturer in family medicine department, and we have the network of family medicine department in our University of Medicine in Vietnam, and we have flexible learning arrangements online in person, and having a system for virtual training, MMS, and media channel. Talking about the opportunity, the Vietnamese government is prioritizing family medicine and implementing relevant policies, and Era 4.0 information technology and AI create change in reaching medical staff with larger number in Ho Chi Minh City and other provinces in Vietnam. And the clinic, we talk about the clinic. We lack of experts in family medicine. Although we have some experts of family medicine in our University of Medicine in Vietnam, such as Assoc Professor Pham from University of Medicine and Pharmacy at Ho Chi Minh City, or Professor Hồ Thị Kim Thanh from Hanoi University of Medicine, or Professor Nguyen Hiep from PNTU University of Medicine, and Professor Nguyễn Minh Tâm from Huế University of Medicine and Pharmacy. But we also lack of experts in family medicine. Yeah, and we lack of staff of professional family doctors. And talking about the threats, the process of coordination between family doctors and specialists in Vietnam has some limitations, and there is a lack of standardization in the practical implementation and training of family medicine among different regions and levels. So the last slide, I would like to talk the solution for the strength and opportunities. We keep building and standardizing the system, and for the quickness, we strengthen international cooperation, learn from experience and exchange expertise, and the opportunity to cooperate with the Học Mãi Foundation. It have a significant, meaningful cooperation for our university and for Vietnam to develop family medicine in the future. Yes, and for the threat, we intensify the organization of interdisciplinary workshops, seminars, conference, and exchange and expertise sharing. Yes, this is my topic for this for today. And the last slide, I would like to present my colleagues in our department. You can see in the picture. It's very handsome and beautiful. Yeah, and they are the young, the dynamic, enthusiasm lecturer, and they would like to, they strongly would like to develop family medicine in Vietnam. Yes, thank you so much. Yeah.
Thank you so much, Dr. Trần Thị Hoa Vi, for her reports. And next, I would like to invite Dr. Warwick Young with the topic primary healthcare models and discussion. Và xin cảm ơn bác sĩ Trần Thị Hoa Vi vì bài báo cáo của cô. Và tiếp theo thì tôi xin trân trọng kính mời bác sĩ Warwick Young với bài báo cáo mô hình chăm sóc sức khỏe ban đầu tại Úc và phần thảo luận.
Thank you very much, and it gives me enormous pleasure to be back in universities, medical universities and hospitals in Vietnam after an absence of, I think, 25 years, believe it or not. So I'm very, very happy to be here and talk about, particularly in the context of Vietnam going down the path of developing comprehensive family medical and preventative care. I'm delighted and honoured to be involved in this. A little bit about what I do in Australia. I'm a rural and remote family doctor or general practitioner, and that takes me to do a variety of things, some of which I don't do so much now. This is me as a retrieval doctor in Central Australia, which is can be part of a job description of a remote general practitioner in Australia. My qualifications, part of the reason I'm doing this particular subject today is because I have a background in economics and political sciences, so I have a particular interest in the structures of healthcare systems and how they can allow the effective delivery of healthcare to a population. I'm a fellow of the College of the Royal Australian College of General Practitioners and the Australian College of Rural and Remote Medicine. Australia is a very big country with a very sparse population, and one aspect of general practice or family medicine in Australia is working in extremely remote communities. This is a clinic I worked in for several years. It's at a place called Iwancha, which is right in the middle of the country. When you work at this clinic, it covers a population of only about 300 to 400 people, very tiny, and the nearest doctor is 400 kilometres away. This is my current practice. I built this with another general practitioner 10 years ago. It's in Port Macquarie, which is a rural location in New South Wales in Australia. But the medicine we do there, the population's about 60 to 80,000 depending on the catchment size. The medicine we do there is slightly rural, but it's really preventative and family medicine in essentially an urban environment. And I think the size of the building illustrates the resources that do go into comprehensive preventative care in Australia. There's 18 GPs in this bit here. In this part here, there's a pathology collection service, X-ray there, and this area here is filled with allied health, physiotherapists, audiology, there's a chiropractor and diabetic educator. And that sort of illustrates the comprehensive nature of primary medicine. What I want to take you through today is to discuss how the background of primary care delivery models and why they end up being the particular way they do in certain countries. And I'm going to look at the United States, Australia in detail, and also the United Kingdom. I'm not going to really reinforce this message. I'm taking that the importance of primary healthcare is understood by everybody. That's an argument for another seminar if it's in doubt. Inherent in discussion about a primary healthcare model is what are the goals of primary healthcare? Because there's two potentially quite conflicting goals. One is triage and first line management of disease, and the other is prevention of disease. And we'll talk about how that evolves in different healthcare models. And I want to finish up by discussing the things that can alleviate the various problems with the different models, generally through government policy. There's obviously a number of universal healthcare challenges, and these apply to all countries, whether they're rich or poor, developing, developed, and this is sort of the starting point. Obviously there's market failure. Poor people can't afford access to medicine in most countries, and so there needs to be some sort of government subsidisation. There is, of course, uneven distribution of healthcare services with, again, the same in all countries, rural and remote areas not naturally getting the same sort of services as city and urban areas. I will focus on this quite a bit. And I've already mentioned it. The idea of acute versus preventative care, first line management of unwell patients by general practitioners or family medicine practitioners versus preventative care. And I use the term crowding out because what is a constant challenge is, particularly when family medicine services are relatively small compared to the population, is that all the energy ends up getting sucked up by emergency care. The unwell patients visit the general practitioner or the family medicine practitioner, and their entire time is spent dealing with those sorts of problems, which leaves very little time for preventative care. That is a big problem in all healthcare systems. There's always tension between medical expertise. Doctors like us would like enormous amounts of money to be spent on medicine. That's inevitable, and governments have to make decisions about how much money they're going to spend on medicine and what the country can afford and what they can't afford. That's totally legitimate. It has to happen. But there'll always be that tension, and that's not a bad thing. I think that's a good thing. Another thing that's common to all countries is there is a political imperative that tends to work against preventative care, and that is one person dying now, a sad story about somebody having a bad accident and they couldn't get the emergency treatment that might have saved their lives. That creates headlines and news in all countries. And that will create a lot more attention and action and funding than a preventative care measure that may cost exactly the same amount of money, but that might save 100 lives in 20 years. And that's a problem that we all face in all countries. I don't want to be too negative, because there are great opportunities out there for all countries as well. The government initiatives and incentives, obviously, increasing wealth. So, for instance, Vietnam is increasing its wealth, and therefore it has more money to spend on preventative care and health generally. Political stability is very important. There's no country in the world that has a good healthcare system that is politically unstable. It just doesn't happen. So countries like Vietnam that are politically stable have the opportunity to do that, and it's very easy to underestimate that opportunity. There's increasing awareness both among populations and government organisations and non-government organisations that public health is something that resources should be put towards. There's also a lot of opportunities that come from technology. So what I propose to talk about is, in comparing different primary healthcare models, is talking about the constitutional restraints. This is something that's not really terribly well understood by doctors in most countries. and explaining the healthcare models that result from these constitutional restraints. In comparing the United States, Australia, and the United Kingdom, we encounter three very different funding models, and I'll talk about them. So this is Australia, talking about constitutional restraints now. Australia is a federation. It was formed in 1901 by the coming together of various colonies of the United Kingdom. And that is the Constitution of Australia. That is actually an act of British Parliament that formed Australia. So the federal government in Australia doesn't have much authority in health. It only has one head of power in the Constitution, and that is found in Section 51, Part 23A of the Constitution. And incidentally, this was added in a referendum in 1946. The Australian government can provide for medical and dental services, but there's a very strong qualification. It is not authorised for any form of civil conscription. And what does that mean? Essentially, I won't go through all of that, but essentially it means that the Commonwealth Government in Australia cannot directly employ doctors. State governments have the residual power to employ doctors directly, and they do in hospitals. That's been a traditional thing that state governments do. However, primarily due to the fact that most tax revenue is raised in Australia by the federal government, state governments do not fund primary care. So you have a situation defined entirely by the legal background, the Constitution of Australia, where all the money that is available to be spent on public health or on primary care is spent by the government that doesn't have any authority to directly employ doctors. And as we'll see, that very much shapes the system that Australia has come up with. In the United States, the USA is a federation, just like Australia. In fact, the Australian Constitution was essentially based on the United States Constitution. In the USA, there's no equivalent of Australia's Section 5123A. However, the federal government in the United States does have the power to regulate commerce, and that is the head of power that is used by the United States government to fund certain healthcare programs, such as Medicare, which is for above 65-year-olds, Medicaid for the disadvantaged. It also has, under the commerce power, the power to regulate private health insurance. This is the United Kingdom, and the constitutional restraints in the United Kingdom. Well, when I put this presentation together, I thought about just leaving this slide blank, because essentially there are no constitutional restraints in the United Kingdom. There's no written constitution. The national government in the United Kingdom raises 90% of tax revenue, and so you have a situation where the central government has most of the money, and it can employ doctors, and it can control where they work, how they work, what patients they see. And I'd make some devolution does occur in the United Kingdom, but that's as policy. It's not a legal constraint on the government of the United Kingdom. So, looking now, what are the healthcare systems, particularly in regard to primary care, that result from these constitutional restraints or constitutional opportunities? And there's three models: capitation, fee-for-service and private insurance, that we'll get into now. The capitation model is what the United Kingdom has come up with, remembering that it is not restrained by the Constitution. So what does capitation mean? It's essentially a general practitioner, family medicine doctor might be paid a certain amount of money, and this is the way it works, for looking after 2,000 patients. And that's it. That's all they get. They have to be responsible for everything regarding their primary and preventative care. The funding is directly from the government. It has certain advantages, this system. One of probably the biggest single advantage with the capitation model in the UK is that most services are provided at no direct cost to the patient. So the cost problem, affordability, and the addressing of market failure is sorted out in the United Kingdom under this model. It's cost effective, some people would argue with that, or at least cheap, and it is cheap. It does have the ability to contribute to preventative and holistic care, providing it's incentivised. Again, this goes back to the dilemma between treatment of triage and immediate treatment of emergencies versus preventative care. If you're a flat-out general practitioner in the United Kingdom and you are looking after 2,400 patients, which is now what it is per GP in the United Kingdom, then and they've got all these demands and immediate pressures, you're going to find it very difficult to find the time to engage in preventative and holistic care unless somehow it is incentivised. You can get a situation where they're just struggling to cope. So another advantage of the capitation model is that in terms of for governments, it means that healthcare costs are largely predictable. They know that the budget next year is going to be reasonably similar to what it was this year. The data collection in the capitation model does make it relatively easy for performance to be assessed, and that's performance of hospitals and general practices. For instance, the NHS has targets. If somebody is diagnosed with a particular cancer by the general practitioner, then the local hospital has an obligation to have that patient seen in a defined time. It may be, say, 4 weeks. And all that information is available, so it's very easy to detect the performance or lack of performance of all the aspects of the healthcare system. And because of these things, there's less need for private health insurance. Disadvantages of the capitation model. I've already talked about the crowding out, and that's a significant disadvantage that again happens in all systems. Related to that is the risk of under-provision of services, simply because the doctor is dealing with 2,000 patients, so the squeaky wheel is going to get all the oil potentially. It may incentivise providers to avoid high-risk patients and simply send them to hospital, which is unfortunate. And it does require appropriate incentivisation to make up for the structural issues that it raises in terms of not dealing with preventative care. There's also a significant problem with the NHS, a risk of doctor burnout. And a lot of doctors in the UK don't like the NHS. Now, the purpose of a health system is not to please doctors, it is to get results, unfortunately. We might not all like that. In the I've set up 2 large practices in Australia, and we have the backbone of the workforce is general practitioners from the United Kingdom. They love coming to work in Australia because they want to escape the NHS and work in a system that does reward them more for a high patient load. So that is a risk to a capitation model. You might lose doctors. Now, in Australia, we have a fee-for-service model, and that is essentially a universal insurance scheme called Medicare that is, like I suggested earlier, is set up really entirely because of the inability of the federal government to employ doctors directly. It's a workaround that restraint. And so what does it mean? It means payments to doctors are based on individual services provided, which can be time-based. For instance, I might spend 20 minutes with a patient and the patient gets to pay me a certain amount of money from the government for each 20-minute appointment. Or it could be procedural. If I take off a melanoma from a patient, again, the patient gets paid a certain amount of money that then is used to pay me. If I bulk bill, which means the patient is charged, but the patient elects for the government payment to go directly to me, then there's no cost to the patient. That's a little detail. The fee-for-service model is essentially private. It's not public. General practices in Australia are private businesses. So the doctors or whoever privately is responsible for infrastructure. So if a doctor wants to open a clinic, they have to build it. Medicare fee-for-service model can be quite bureaucratic, and the Medicare benefits schedule describes all the benefits that are available to doctors and including primary care physicians, including all private specialists. And it's a big, thick book that has 57,000 item numbers. Each doctor will get a provider number that gives them the right to bill Medicare, but also refer for services. And the provider numbers are location specific. So if I want to go and practice in a different location, I can, but I need to apply for a provider number in that location, which will usually be given. There are bulk billing incentives in primary care medicine, and they're very important. It's generally expected that patients that have money will contribute something to their healthcare in primary care in Australia, whether right or wrong. But bulk billing incentives for patients that are poor, and they might have concession cards or healthcare cards, an important incentive that again helps overcome the natural market failure of healthcare. I've just chosen a fairly random example from the Medicare benefits schedule. In a way, this gives an example of how it can be quite bureaucratic. This is for spirometry in general practice, but it can also be done by a specialist. And it gives a defined benefit of $39.90 if I perform this in the practice. So a spirometry, bronchodilator, post-bronchodilator, spirometry, and then I can bill this item number or for the benefit of the patient. This particular item number is when the pre-post spirometry is used for diagnosis. There's another item number when it's used for monitoring. So you can see that it can get quite bureaucratic. What are the advantages of this model? And some, depending on the way you look at some of these advantages and disadvantages, some of the advantages might actually be considered a disadvantage. It certainly incentivises high volume of care, which can be a double-edged sword. If I have a patient who's motivated to really look after their healthcare conditions, for instance, a newly diagnosed type 1 diabetic, which I see a lot of because I am one myself, I can get them back every day if need be, if they're having trouble sorting out their sugars and avoiding hypoglycemia. Every day would be unusual, but I can prioritise what I do and still get paid for really intensive service. Now, that of course could be abused. Part of that is it gives, fee-for-service does give great patient choice. If the patient doesn't like their doctor, they can go and see another doctor. They are not tied to any particular practice or any particular doctor. And given the importance of the personal relationship between a primary care physician and a patient, I'd say that's actually a reasonably significant thing. There's a question mark as to whether it's efficient or not. In terms of governments, its cost is less predictable. For instance, if a new item number comes out for something, it's very difficult for a government to predict exactly how often that number will be billed. And so it's very difficult even for something that's been established for a while, like the removal of a melanoma. The government can't tell how many melanomas there are. If there's a particularly bad year for melanomas or respiratory illnesses, then the cost will go up. In the capitation model, the cost doesn't go up, but it gets absorbed effectively by the primary care physician. The fee-for-service model, particularly in terms of primary care, does allow for subspecialisation, which is potentially a significant thing in primary care. Lots of general practitioners like to have their own areas that they have a little bit of more of an interest in. General practice and family medicine covers a lot of ground, and a lot of larger practices will tend to have a doctor, one family medicine specialist who practices a little bit more in certain areas. For instance, I do a lot of type 1 diabetes in my practice. Another doctor does a lot of rheumatoid disease. And it makes for a very effective collegiate environment, as well as very good service for patients, because they can be internally referred in the general practice. The fee-for-service model does allow for workforce incentivisation programs based on Medicare billings, and this is a significant policy of the Australian government. So because the data is all available on Medicare billings and where those billings are occurring, it makes it very easy for the government to introduce incentives based on Medicare billings to encourage doctors to spend time in remote and rural areas. So the government can see, oh, this doctor has billed so X amount of Medicare billings in this particularly poorly serviced area, so we can pay that doctor X amount of dollars as an incentive. And the incentives are quite reasonable. For the remotest areas in Australia, it's the incentives are roughly the equivalent of Australian average weekly earnings each year. And the existence of the Medicare billing system allows that to happen very easily. Disadvantages? It certainly may lead to overutilisation of services, particularly well-funded services. What does this mean? You may have a procedure that is able to be done very effectively and efficiently by a doctor, and that may become over-serviced, and that certainly does happen sometimes. Most services are not actually, in the end, provided at no cost for the patient. So there's an element of impingement on the goal of fixing market failure in medicine. There is the potential for fraud, and again, that certainly happens. There's one doctor that I came across in training who's now in jail for billing patients that were dead for 3 years, and so there is the potential for fraud. And another disadvantage is that the fee-for-service model does not in itself address workforce maldistribution, but the policies that can come with it, as we talked about earlier, can. So some of the strategies, and we've touched on some of these, to overcome the deficiencies of the fee-for-service model, making sure that the MBS schedule of fees is kept up to date, making sure that bulk billing incentives are meaningful and do actually allow for patients to access services without having to make a substantial out-of-pocket payment. You can, by adding particular item numbers, you can incentivise primary healthcare priorities. And these are two fairly effective measures. Elderly health checks. These are for all patients 75 years and over. Medicare will fund a comprehensive health assessment each year for these patients. And that encourages advanced care directives, encourages falls risk assessments, encourages screening for visual problems that can be easily treated, and a whole range of other things. And there's also management plans that can be applied to any patient with complex care needs, and again, they're well funded to encourage them to be done. Strategies to address workforce distribution, apart from the workforce incentives programs that I talked about in the last slide. These are separate to Medicare, but putting universities and postgraduate training in rural areas. For instance, in Port Macquarie, now with a population of just 80,000, you can do your entire undergraduate medical degree there now. And that's been a policy of both state and federal governments for now 10 to 20 years to get the training of doctors to rural locations. Rural workforce incentives we talked about. The governments can also provide infrastructure. For instance, they might have a program which they have to provide infrastructure, so provide a clinic for doctors to practice in, which would, and do that in areas of need. There's the opportunity for formal and informal performance indicators that may be met with a financial reward or may not, but certainly even just bringing clinical performance measurements to the attentions of groups of doctors can compare to your colleagues can certainly result in improvements of services. In general practice, simple things like making sure that on the computer software that we use to hold patient data, making sure their allergies to medications are kept up to date. Because if they're kept up to date, that significantly reduces the chance of inadvertently prescribing something that you know a patient is allergic to. And the way the software is, it will detect that. If your allergies are up to date and they've been entered correctly in a mineable form, then the software will warn you when you try to prescribe something that they are allergic to. Another way to combat the deficiencies of the fee-for-service models, well, this is a whole list of things here. Meeting practice accreditation standards, i.e. practices get to bill higher Medicare rates if they have passed multiple tests for accreditation. There's incentives for providing after-hours care for the patients of that practice. There's incentives for providing doctors within the practices access to electronic clinical resources. There's incentives for meeting local community demand. And importantly, there's incentives for each general practitioner to teach. And another obvious thing that the federal government does is it audits Medicare to try and reduce fraud. In the United States, like Australia, as we mentioned, the federal government doesn't have the power to employ doctors, but they've come up with quite a different system. And I'm conscious of time, I won't go into this too much. But the US, there's no universal health system. There's the two main federal government programs that I mentioned earlier. The United States system is very different in that it's largely reliant on private health insurance. So 58% of the population is privately insured and receives no direct government funding or indirect government funding. And for approximately half of the population, these private health policies are paid for by your employer. It's quite a unique system. And if you are employed, it actually works very well. If you're not, it doesn't necessarily work so well. There's many different models available, many different types of healthcare insurance, which have a range of co-contributions from the patients, varying from a lot to none. Just by comparison, in Australia, 39% of people do have private health insurance, but the private health insurance in Australia is a vastly different thing to private health insurance in the United States. This does everything for the patient, it pays for everything. This pays for limited services above what you would get in a public hospital, like for elective surgery, so non-emergency surgery, you will get done faster if you have private health insurance. And you might get a private room in a public hospital, maybe, if you have private health insurance. The UK, because of the more comprehensive nature of the capitation system, has a very low proportion of people insured privately. What are the advantages of everybody likes to give the United States a hard time for its healthcare system, but there are some advantages to the private health insurance that are worthwhile discussing. First of all, it does overcome the constitutional restraints. It is one way of doing that. This is an interesting one. Because you have a health insurance policy and somebody in New York might have that policy, somebody in a very poor area in the Midwest might have the same policy. Under that policy, they are obliged to get exactly the same service. So it is a significant mechanism against the problem that occurs in a lot of countries where people in rural and remote areas don't end up getting the same degree of service as they do as people in larger built-up areas where there are a lot more doctors get. So it does actually play a very significant role in improving services in rural areas, which is something that's not recognised that much. I won't go into any of those. The disadvantages are it ends up being very high cost. A comprehensive private health insurance scheme ends up being costly. There's no doubt about that, and I've got some slides at the end to show that. People would argue there's significant inequality, and well, there is. At least it's more obvious where the inequalities are. If you're looking for the purpose of a health system to provide both primary and preventative care and also emergency care, we've all heard the nightmare stories of where somebody who is poor turns up to a private hospital in the US and they get refused treatment. In reality, that very rarely happens, but when it does, it certainly makes headlines. And there is fear that people have in the United States that if they don't have comprehensive private health insurance, they might not get treated, which is something that I think is probably best avoided in a good health system. Traditionally there has been, with private health insurance, less focus on preventative care, although there's a bit of evidence that is changing as the health insurance companies are accepting the argument that if they invest a little bit in primary care, then they might actually reduce their own costs in acute care down the track. And so there's the question of efficiency, and I've put this slide up here to compare two little bits of data that is at risk of being overinterpreted. But this is so healthcare costs as a percentage of gross domestic product and life expectancy. So the United Kingdom, 10% of GDP is spent on the NHS, and life expectancy is 81 years. In Australia, 9% is spent on health. Now, in getting this data, I always question some of this data because there's many payments that are made in all countries that almost certainly do not make this data. But anyway, in Australia, the stats from 2021, and this is World Health data, 9%, life expectancy 84. So if you judge that alone, maybe we're doing something right. The US is very different in that it's 18% of GDP, but life expectancy is 76 years. I think that's probably a bit unfair on the US because there's an element of education involved in that as well. Generally, medical degrees aren't subsidised in the US, so charge costs are higher effectively because loans from students have to be paid back. So that probably is overestimated because there's an important education component in it. So where does this leave us? Well, I think in the context of Vietnam developing its primary care system, if there's any overwhelming message, it's probably make it work for you. The policy responses of other countries are essentially based around the limitations of the legal system and constitution underlying the government, and they're essentially policies that are developed to just try and make something work. And now, having said that, it's important to understand that, and it's important to understand the policy responses, and it's also important to understand how some policies that can be implemented to make up for the inadequacies of each individual system. And there's no such thing as a perfect system. There's a few common themes to fixing the problems with all healthcare systems. You need some form of incentivisation in all systems, and location-based incentives, performance-based, targeted public health programs that go over the top of the individual provision of healthcare services by doctors to individual patients. Probably the good place to finish is the making the point that in the development of primary healthcare, and this will be an enormous challenge for Vietnam, is the capacity of primary healthcare physicians to be completely busy with acute medicine and triage, certainly in the early stages, and the importance of protecting preventative care and management of chronic disease from being completely dominated by emergencies and triage. Thank you very much.
Thank you so much, Dr. Warwick. For the discussion, we will discuss after the presentation of Dr. Sĩ. Okay, so we will have the final sessions. discussion. Yes, thank you. Xin cảm ơn bác sĩ Quang Quyết Dân. Và vì bài báo cáo của bác sĩ thì sẽ có thêm phần tham luận, nên quý vị đại biểu nếu có câu hỏi thì chúng ta có thể soạn thảo trước, và chút nữa thì đến phần tham luận của tổng một phiên thì chúng ta sẽ có thể đặt câu hỏi cho các vị báo cáo viên ngày hôm nay. Và tiếp theo bài báo cáo tiếp theo là xin được mời tiến sĩ bác sĩ Trần Đức Sĩ, giảng viên bộ môn y học gia đình trường Đại học Y khoa Phạm Ngọc Thạch, báo cáo chủ đề triển khai chương trình TOT Training of Trainer nhằm quản lý bệnh nhân tăng huyết áp và đái tháo đường tuyếp 2 tại tuyến y tế cơ sở Việt Nam. Xin trân trọng kính mời thầy. Next, I would like to invite Dr. Trần Đức Sĩ, lecturer of Family Medicine Department, to report the topic Implementation of the TOT Training of Trainer program to manage patients with hypertension and diabetes in primary care in Vietnam.
Good morning. I'm Dr. Đức Sĩ from Department of Family Medicine, Phạm Ngọc Thạch University. I'm also lecturer of the TOT program and take charge of the south of Vietnam. So today I would like to discuss several key aspects related to the management of the hypertension and diabetes control in primary care in Vietnam. So I have too much to say here, and it's quite late, but I will try to speak as fast as possible. So this slide will provide a comprehensive overview of the presentation. So first, we will begin with the introduction to the patient management program, and next I will talk about the contribution of PNTU University in the TNT activity, and at the end we will talk about the lesson learned from the program. In Vietnam, the treatment gave in managing hypertension and diabetes notably pronounced. Data revealed that only more than 43% of hypertensive patient diagnosis and only 13.6% patient control. And the problem with diabetes is also very poor detected, with 68.9% undetected and only 28.9% patient well controlled. So the disease are both chronic disease and require long-term medication, and so patients go for treatment at the public health facility, but most of them go to the provincial and district hospital, and few people come into the dispensaries or the health station for the treatment. Indeed, the dispensaries in Vietnam are very suitable for the management of hypertension and diabetes for many reasons, and one of them is the chronic disease are often linked to the lifestyle and behavioral factor. So it makes health education essential to raise awareness and promote healthier habits. Then many cases would be preventable, notably up to 70-80% of the patients are in moderate and mild start, which can be effectively managed and treated in the dispensary. So with the accessibility and community focus at the health system, we can manage the patient adequately. Okay. Yeah. However, there is a notable disparity in the utilization of the health care facility, and on the slide you will see
The high-level hospitals are often crowded. Often overwhelmed with patients, leading overcrowding and strain on resources. And this situation arises because many individuals bypass the local health station and go directly to the advanced facility seeking for specialized care. So there are very few patients at the health station, the local dispensary. So we pass this. So that's the principle of the family medicine in Vietnam. So we know that the local dispensary are well acquainted with the local area and have established connection through community program and network of collaboration. So this enabled them to adopt a patient-centered approach that consider the patient and environmental context of each individual. So that's why the Ministry of Health has launched a program to improve medical capacity at the grassroots level, in which the management of the hypertension and diabetes, according to the principle of family medicine, is the main focus. The program started in 2018, carried out principally in 2019, and interrupted because of the COVID-19. So above the circular and decrees of the Ministry of Health on the implementation of the family medicine at the primary care in Vietnam. The local dispensaries play a crucial role in the management and treatment of hypertension and diabetes in Pokomy. Their role can be outlined as follows. In the summary, the local health station integrate to a comprehensive approach to managing hypertension and diabetes, addressing prevention, treatment, community support, and information management. In the program, the dispensary, the health station, is responsive for screening, preliminary diagnosis, treatment, updating progress, managing each patient record, and making statistics. The dispensary is also transfer patients to higher level to do the necessary tests. So they can transfer patient to the hospital or the provincial hospital, district or provincial hospital for the test periodically or when having the complex case. And at the hospital, they will treat the patient, do the test, and return back the patient to the primary level for continued treatment. The referral activity have also been clearly defined in the TOT program, in which the basic level is responsible for clinical monitoring and determining the time to transfer patient to a higher level for periodic tests according to the protocol or within the schedule. For example, the diabetic patient needs to the diabetic patient need to refer to the higher level for the HbA1 test every 3 months. And when the glycemia is stabilized, the primary level can refer the patient to the higher level for the test every 6 months. Next, I will resume the contribution of the PNTU University in facilitating the TOT activity. Our Department of Family Medicine conducted the continuous formation for healthcare staff from dispensary, hospital, and some provincial health policy decider in many provinces in Vietnam, twice in some provinces. In the picture, medical staff, practitioners, and instructing people to use capillary glucose test and other simple tools. And after the program and TOT program, I think that we used to think that the difficulty hindering the development of family medicine in Vietnam lie in the number and quality of the current family doctor. However, through the implementation of the hypertension and diabetes program, it has been so that a broader view is needed. Indeed, the biggest challenge for the program is the coordination between the family doctor and other specialty, especially receiving patient transfers back from high-level hospital. Here in Vietnam, if you ask a specialist about the schedule for follow-up visit with family doctor for chronic condition after discharge from the hospital, you will rarely get an answer. In reality, doctor often only schedule patient to return for a follow-up examination at the hospital after a few days or after a month, regardless of geographical distance, mobility, or other condition of the patient. In fact, in the training program for doctors in other specialists in Vietnam, there's no content about the coordination with the family doctor. So in our healthcare system, effective coordination is essential for managing chronic non-communicable disease such as hypertension and diabetes, I think. So in that, the main point is the collaboration with specialists. We need to actively engage in discussion we need actively engage in discussion and collaborate with the other specialists on the monitoring the schedule for the chronic non-communicable disease, not only for the hypertension and diabetes, but for all other chronic disease. And it's very hard because we have no experience about that before. We have no collaborations between family medicine and other specialists before, and almost of them don't know about the role and the principle of family medicine. It's quite new in Vietnam. I think that the collaboration between specialized doctor and family physician is vital in the effective management of hypertension and diabetes. So prioritizing referral activity will ensure that patients receive appropriate care close to their home, with enhances their adherence to treatment and follow-up. So when the specialist manage the complex case and then transfer the patient back to the local health station, the family doctor will maintain continuity of care by utilizing comprehensive patient record. So this system will allow for better monitoring and management of chronic condition, especially hypertension or diabetes. So in conclusion, addressing this issue is essential for improving the management of chronic non-communicable disease through family medicine principle. Enhance communication, clear role definition, and better referral and feedback practice will contribute to a more effective healthcare system. Thank you for your attention, and I look forward for any question and discussion you may have. Thank you.
Xin cảm ơn tiến sĩ bác sĩ Trần Đức Sĩ. Thank you so much, Dr. Trần Đức Sĩ. Và sau đây thì chúng ta sẽ cùng đến phần tham luận của phiên thứ nhất của buổi seminar ngày hôm nay. And now we will move to the discussion of the session 1 of today's seminar. I would like to invite Dr. Stephen Pokomy to chair the discussion.
Thank you, T, for your excellent talk, for Duxi and for Warwick. Could I ask T, first up, we've been coming to Vietnam for many years and we just don't know why primary care is not the basis of your health system. In every other country, people, particularly Australia, people go to their family doctor and they decide whether they can investigate you, whether you need to see a specialist or whether you need to go to a public hospital or private hospital. But in Vietnam, my understanding is the people prefer to go straight to the hospital, the big hospitals, which are then so overcrowded that it's very hard for anybody to get proper care. So why is it that primary care is still in its infancy and didn't sort of start many years ago?
Yeah, thank you for your question. Indeed, in Vietnam, we are a communist country, so we have the public system to cover all the patient, all applicant, and before we have a system of the dispensaries, the health station, the local health station, and before the local health station occupy also the treatment and preventive touch. But for the recent decade, we concentrate in the preventive activity more than the treatment. And after that, the patients start to go directly to the hospital seeking the specialized because they lost the trust on the clinical capacity of the primary system. And now we try to convince them to come back to the dispensary for the diagnosis and treatment for the medium or the mild health problem instead of go directly to the hospital. But it's a hard problem because they have the habit already. So indeed the role of the primary system is very low underestimated by not only the patient but also our colleague in the hospital. So now when the patient go directly to the hospital, they won't send back the patient to the primary system for continuity treatment. So that's why I try to That's why I said that we need to collaborate better with the other specialists and explain to them the role and the capacity of the family medicine and also of the primary care system, and convince them to send back the patient to us.
Thank you. But I think you said they won't, if they go to the hospital, they won't send them back to the family medicine doctor? Why?
Because they don't have to send back the patient, and they don't think about that.
But they should think about it.
Yeah,
I mean,
that's
it
right.
takes
They
the
should
pressure
think
off
about
the
that.
hospital.
Yeah, they should think about that. Yeah, that's what I mean. Yeah.
The other thing is, and this happens in Australia too, if somebody goes to the public hospital, it's very hard to get the information what happened at the hospital. Like in Australia, we give a discharge summary, and I think they're starting to do that here, but I know if somebody goes to one hospital and 6 months goes to another hospital, the second hospital has a lot of trouble getting the information from the first hospital as to what happened to them.
Yeah.
Why is that?
Here too, because we don't have the connection between the hospital. Only the state assurance can have information, but they use that just to check the activity for the refund, for example. But to know the reason of the laboratory test or the reason, the diagnosis of the patient, we need to take the paper who come with the patient, but we cannot connect directly to the informative system to get the reason, for example.
Please, may I ask a question? I'm just wondering what role nurses play in primary health care, and do you have nurse practitioners? Nurses who may be able to do things like insert IUDs or something like that. I don't know. I've tried to find out about nurse practitioners in Vietnam, but not come up. The internet didn't answer my questions.
Yeah, indeed, the family medicine is quite new in Vietnam, and now we concentrate in the formation of the doctor. We have some formation, the short formation for the nurse to know about the principle of the family medicine, but not a lot. Yeah.
Mm. In Australia, there's a move for pharmacists to become more involved in informing patients, making sure that they're not having polypharmacy, too many drugs, the same drugs, all that sort of thing. Are pharmacists evident in, important in primary health care in Vietnam?
No.
Perhaps that's an unfair question. You're focusing on the doctors. Yeah. Yes. But
here, each doctor give their ordinance. Sometimes the patient go for specialists from different hospital, and they just like you just said. Sometimes they have the same drugs in 2 or 3 ordinance at the same time. Yeah.
Right. Thank you. And Warwick, I'd just like to ask you a question.
Yeah.
You talked about various paramedical people, but you left nurses out. I assume there are some nurses in your multidisciplinary GP practice.
Yeah, that's right. There are.
And what about nurse practitioners?
Well, there's no nurse practitioners essentially because number one, they're not available. Two, they're not funded.
Okay.
So, but the point you were raising before is I do think there's there's two separate models of involving allied health, nursing, and you know, wide range of allied health and nursing in primary care. One is getting highly qualified nurses to work as nurse practitioners, and another is to get significantly increase the what each individual doctor is capable of doing, and they can be pretty simple tasks like population-based blood pressure screening. One doctor can look after 20 nurses doing programs like that, and they don't have to be terribly experienced nurses. They just have to be able to do some fairly basic things. And I think there's a massive role for that. I wouldn't advocate going down the path of potentially creating more silos, which can happen a bit in Australia potentially, but certainly making, particularly in the context, and this again applies to all countries to some extent, where there's a limited number of doctors, particularly in primary care, leveraging them by with a supportive workforce with good evidence-based protocols and training, so that the person who's at the coalface, that might be a quite junior nurse taking blood pressure, knows things they should be looking for to report back. And a system like that can be very effective. And I would suspect there's a bit of gold in that for what you guys are doing.
In fact, we have not very policies for family medicine in Vietnam. We just start, and we focused on the local station. But we just start. We have a trained nurse in family medicine. I have trained. And but there is no policy to protect our nurses, so they cannot work. And what I say, for the question why the doctor in hospital keep their patient, because if they return the patient to the family doctor, they will lose this patient. And so they will lose money because the patient paid to the hospital. So they keep the patient in the hospital, and the hospital was a very, very hard, many population patient in the hospital. But at the level of a local station, there is nobody want to go. But I think I say to you that we start, and when can we apply the system of family doctor, the very, very good system in Vietnam? I hope it will be soon, but I cannot say when. This is we have not policies at this time. Nothing. No insurance, medical, nothing at this time. But it will be in the sooner time. Yes. Dr. Yang. He is the chief of family of all our health service.
Xin lỗi, tôi xin nói tiếng Việt nha, rồi phiên dịch giùm. Đúng rồi, dịch luôn này.
Thank you so much.
Cái thứ nhất là khi tôi đến đây theo lời mời của hiệu trưởng của nhà trường á, thì tôi chỉ dự định đến để nghe thôi. Nhưng mà qua các cái trình bày của các bạn ở Úc và đặc biệt là những câu hỏi được đặt ra, tôi lại cảm thấy hứng thú và cũng muốn tham gia để chia sẻ.
First, when I came here, I just want to listen to your reports. But then, when the discuss come in, and I really it's really interesting for me, and I want to join the discussion with you.
Hiện nay đó ở thành phố Hồ Chí Minh đó, thì có khoảng 1.500 bác sĩ gia đình đã được đào tạo.
Right now in Ho Chi Minh City, there are around 1,500 of GPs, general GPs that are educated.
Nhưng mà hỏi rằng có ai đang làm đúng là một bác sĩ gia đình hay không và sống bằng cái nghề bác sĩ gia đình hay không, thì câu trả lời có thể nói rằng là không có ai hết.
But when we ask if they practice their role, the correct role, and if they can live with their GP's title, can they live with that? I can answer that is no.
Và ở thành phố Hồ Chí Minh có phòng khám bác sĩ gia đình hay không?
And is there any general practitioner clinic in Ho Chi Minh City?
Thì câu trả lời là có.
And the
không
answer
nhiều
is yes.
Nhưng mà là có.
And
Cũng
it's not
vài
too much,
chục cái
but
phòng
there
khám
is.
bác sĩ gia đình đang có ở thành phố Hồ Chí Minh.
There's around several of them, maybe
vài chục.
Around a dozen, maybe 10 to 90, around that.
Nhưng mà hỏi rằng có phòng khám bác sĩ gia đình nào làm đúng nghĩa, đúng các nguyên lý của bác sĩ gia đình hay không, thì câu trả lời là không.
But about their scope of work, if they do the correct role of the GPs in their clinic, the answer is also no.
Và Sở Y tế thành phố Hồ Chí Minh hỏi ý kiến tôi là bây giờ có thể làm cho ra đời những cái model mà bác sĩ gia đình, thí dụ như của Cuba, của Anh, được hay không? Thì câu trả lời của tôi với Sở Y tế là không.
When the health department of Ho Chi Minh City asked me if we can mimic the models of other GP's clinic from another countries, for example Cuba or the England, the UK, can we mimic that to imply into the Ho Chi Minh City as well as Vietnam? My answer is also no, we cannot.
Thì mới hỏi tôi tại sao. Chắc các bạn cũng sẽ hỏi tôi câu đó, tại sao?
And they asked me why, and I assume that you also asked me why.
Và câu trả lời cực kỳ đơn giản, mà tất cả các bạn mà ngồi ở Việt Nam mà bác sĩ gia đình đều có thể trả lời, đều có thể đồng ý với tôi. Đó là không có đất sống.
And the answer is really simple, and I know that every GPs in Vietnam, you have the same answer with me, that we cannot live on this land with the GP's title.
Tức là cái người bác sĩ gia đình ở đây mà hành nghề bác sĩ gia đình của mình, phòng khám bác sĩ gia đình mà hành nghề phòng khám bác sĩ gia đình, thì sẽ không có thu nhập.
If in Vietnam we practice correct GP, the general medicine, we cannot have enough income to live.
Tại sao không có thu nhập? Thì trở lại là không có đất sống, không phải chỉ là cái thu nhập đâu. Thu nhập chỉ là cái kết quả của không có đất sống thôi. Tại vì người ta lấy hết đất rồi. Còn đâu để cho anh có đất để mà anh trồng tỉa, anh thu hoạch nữa, không còn.
So we don't have enough income. It's because somebody else had took that part, and we don't have any place to perform our practice.
Như hồi nãy các bạn hỏi vậy đó, là bệnh nhân đi đâu? Bệnh nhân có gì là chạy thẳng lên bệnh viện, thậm chí bệnh viện cao nhất, chứ đâu có dừng lại ở dưới đâu.
As Professor Chris has asked, when the patient need to meet the doctor, where will they go? And the answer is they will go directly to the hospital, but do not go to the GP clinic. So the hospital will keep the patient, and then we don't have any land to live, or we don't have anything to perform the GPs.
Một trong những cái nguyên nhân rất đơn giản là bảo hiểm y tế ở Việt Nam là đăng ký ban đầu ở bệnh viện.
And the answer is really simple because the health insurance in Vietnam is initially registered at the hospital, not the clinic.
Vì vậy đó là người ta phải xài cái bảo hiểm thì người ta phải đến với bệnh viện.
And they need to use the insurance to cover the fee, so they need to go directly to the hospital.
Và trước đây tôi đã thử nghiệm bằng cách đó là cắt cái đăng ký ban đầu ở các cái bệnh viện mà của cấp thành phố.
And initially, I tried to cut the registration of the insurance at the hospital in the city base.
The city hospital.
Yeah.
Để dồn cái đăng ký ban đầu về cho cái tuyến quận huyện.
And try to push the registration of the insurance to the territory system, which means based on the ward or the district hospital.
Và bắt đầu chuyển cái cho đăng ký ban đầu tại trạm y tế, không phải đăng ký tại ban đầu nha, đăng ký ở trung tâm y tế nhưng mà trạm y tế được thực hiện cái bảo hiểm y tế.
And I try to force that policy that the citizen can register their insurance at the health station of their rural area.
Và tạo điều kiện để người bệnh về trạm y tế bằng cách là người bệnh nếu đến trạm y tế thì không phải chi trả cái đồng chi trả 20% như là đến với các cái tuyến khác.
And I try to create a friendly environment for the citizens that register the insurance at the health center, that they don't need to pay extra 20% fee when they compared to when they go to the hospital, because they need to pay extra in the hospital. And at the health station, they do not pay it. They do not need to pay anything else.
Thì nó có một chút tiến bộ,
And
nhưng mà sau đó lập tức là sự phản ứng mãnh liệt của các bệnh viện thành phố vì nó vắng khách, nó hết quá tải.
The work I tried, it improved the situation, and then there's a really huge response from the large hospital. They try to reject that procedure.
Cho nên phải chấm dứt cái chủ trương này.
And we need to stop
để
that.
trả cái đăng ký ban đầu lại cho bệnh viện thành phố.
And the old procedure came back. Patients need to register in the large hospital.
Như vậy tức là cái bác sĩ gia đình là còn dưới cái trạm nữa, là chừng nào mới có đất sống. Mới đang tạo cái đất sống cho trạm y tế thôi, mà tạo còn chưa được mà. Vậy thì chừng nào bác sĩ gia đình đây mới có đất sống?
So the situation in Vietnam is the GP is recognized really low, and they are even lower than the territory health system. So how can we improve that is really a hard question.
Có một phòng khám bác sĩ gia đình cũng rất là nổi tiếng ở quận 2 á.
There's a really famous GP clinic in District 2 in Ho Chi Minh City.
Cũng là cái nơi để triển khai thí điểm của một trường đại học.
And that is a place to employ the GP practice from another university in Ho Chi Minh City in that clinic.
Và khi tôi hỏi, cái phòng khám đó nó nằm trong cái khu phòng khám của cái bệnh viện quận.
And that clinic is it's built within a general department in a district hospital.
Như vậy là nó tồn tại cùng một lúc phòng khám bác sĩ gia đình với những phòng khám nội, phòng khám ngoại, phòng khám tai mũi họng vân vân.
So the situation is there's a GP clinic within besides another clinic like internal clinic, external clinic, and etc.
Và tôi hỏi người phụ trách phòng khám á, phòng khám của em có gì khác với mấy cái phòng khám bên cạnh?
So I asked the head of that clinic, what is the difference between your clinic and another clinic?
Và câu trả lời là không có gì hết.
And the answer is there's no difference.
Bởi vì cái phòng khám này nó cũng không làm một cái gì theo nguyên lý của y học gia đình hết.
The root of that question is the clinic, they do not perform the correct role of the general medicine.
Và bây giờ tôi nói nỗi đau của cái trường đại học này.
And now I talk about the pain of this university.
Cái phòng khám mà chắc quý vị đã tới coi rồi ở đây.
And in our university, we have a polyclinic, as Dr. Hiep mentioned before, and that polyclinic is based on the general medicine.
Đầu tiên đây ra đời đó, nếu tôi nhớ không lầm thì nó ra đời là phòng khám bác sĩ gia đình.
And before the name polyclinic came in, we named that general medicine clinic.
Và một thời gian sống không được.
And after several times, they cannot live without that.
Và xin đổi thành phòng khám đa khoa.
And they changed to the function that the polyclinic.
Đấy, tôi nói tất cả cái thực tế để chúng ta, khi chúng ta nói tới đào tạo, chúng ta nói tới lý thuyết rồi nguyên lý, thì giờ tôi thấy rằng chúng ta nhìn, tôi muốn nói cái thực tế để chúng ta cùng bàn với nhau coi có cái gì để giúp cho Việt Nam được hay không.
So we have discussed a lot about the theory, the practice, but now I want to discuss about something we can imply into the Vietnam situation to improve this.
Tôi qua Úc nhiều lần và tôi có rất nhiều bác sĩ là bạn đang làm bác sĩ gia đình ở Úc. Cho nên tôi cũng có hiểu được cái mô hình này của Úc.
And I have visited Australia several times, and I have a lot of friends and colleagues from Australia that are GPs, and I understand the system of GP, general medicine in Australia.
Và qua trình bày của ông vừa rồi thì tôi thấy rằng cái mô hình mà bác sĩ gia đình của Úc á, nó có vẻ gần gũi và có thể ứng dụng được ở Việt Nam.
And through the presentation of Dr. Nguyen, I understand that the system in Australia is really relative and kind of similar to the situation in Vietnam, and we can use that system to imply to the Vietnam situation.
Cho nên đó là tôi nghĩ rằng, và tôi cũng rất là mong muốn có sự hợp tác giữa Đại học Phạm Ngọc Thạch với các bạn ở Úc để xây dựng một cái mô hình thí điểm ở tại cái phòng khám này nè. Nó là một cái mẫu để cho, trước tiên hết là việc thành phố Hồ Chí Minh, các nơi khác nhìn vô, người ta thấy nó có thể thực hiện được, chứ không phải là không thể, nó có thể, và từ đó nó mới làm một cái điểm, một cái đốm lửa ban đầu để nó mở rộng ra, nó mới phát triển được cái y học gia đình ở thành phố Hồ Chí Minh và ở Việt Nam.
So I really hope that there can be collaboration between the polyclinic at Phạm Ngọc Thạch University of Medicine and you, the Australian experts in the GP field. So we can imply that directly to the polyclinic of our university, and that can be a model to other GP clinic within Ho Chi Minh City and then the Vietnam. So that clinic, I envision that to be a trailblazing clinic that everybody, another places, they can learn from us with your help.
Bạn Vi thì nói với tôi rằng các bạn học mãi ở đây đó chú trọng tới cái việc dạy thôi, dạy để học mãi.
And as far as I know, the Học Mãi Foundation, you are focused on educating,
training.
And training.
Nhưng mà học nó có nhiều cách, phải không? Cũng có cách là learning nhưng mà by doing. Cho nên dạy cho các cái bác sĩ ở đây nè, là cho nó làm, cho nó đúng, thì đó cũng là một cách dạy hơn là dạy ở hội trường.
So there will be various methods to educate somebody. So it's very effective if we can have the practical education at the clinic, so that you can teach the doctors there how can they perform the GP correctly rather than just doing only seminar.
Chúng tôi và lãnh đạo của nhà trường đã bàn và đã thống nhất là thay đổi cái phòng khám đó theo đúng hướng bác sĩ gia đình.
And I and also the head of our school have discussed and tried to reorient the clinic again to perform the correct scope of work of the GP.
Và bây giờ sự rất là cần thiết là các bạn sẽ tham gia, sẽ hỗ trợ để biến cái ý định này thành hiện thực,
And
giúp cho Việt Nam.
It's very important to have your help and your assist to make that discussion to be true, to help the clinic to perform in the correct way and be the trailblazing in Vietnam.
Xin cảm ơn sự lắng nghe và cũng xin lỗi đã lãng phí thời gian của quý vị quá nhiều.
Thank you so much for your listening to my idea. Cho em hỏi là không biết trong hội trường mình còn ai có câu hỏi nào cho chủ tọa không ạ?
I think, in our opinion, I want to ask about telemedicine in primary care of Australia. Telemedicine, how apply? Okay, thank you. We use this in emergency medical emergency situation in family. Telemedicine. Yes.
Well, there's a lot of different applications of telemedicine in primary care. Let me just say at the start, I love hearing and feeling the passion from the primary care specialists and professors. I really enjoy seeing that immensely. And I understand the political challenges that you face. Funnily enough, there's very similar political challenges in all countries. But you might be coming from a slightly more extreme situation here in Vietnam than we deal with at the moment in Australia. And that partly has to do with how long the systems have been in place. But I really enjoy hearing your passion immensely, and I'm honoured to be, help in the tiniest little way. In terms of telehealth, like a lot of developments in medicine, it comes about when there's a crisis. Before COVID-19, there was really no telehealth in general practice. It had to be, Medicare would only fund patients when they turned up and you saw them face to face. So there was nothing by telephone and nothing by video. Now COVID changed that because it was absolutely necessary. Otherwise the entirety of probably the medical workforce would have been wiped out by COVID temporarily. So now that having been said, telehealth, once it started, governments are not going to be able to get rid of it because it's so good. It is so good. So in Australia, there are item numbers for primary care physicians that they can bill Medicare for telephone calls and for video calls, both of which have their role. You certainly get more clinical information on a video if it's available, but obviously lots of elderly patients particularly don't have the capacity to use a video. So telephone is useful there. And for patients that find that can't drive, they can't get about, they can't get in, the telehealth is extremely valuable, particularly for situations where you might be following up results. You've already had the opportunity to examine them physically, which obviously you can't do by telehealth, but particularly for following up, particularly for triaging, and particularly for certain aspects of preventative care, telehealth is extremely valuable, and it's really being used a lot in Australia now, to the extent where at my clinic in Port Macquarie, we now wish we hadn't built such a large waiting room because it's not full like it used to be, because we're doing a lot of telehealth.
Thank you. And there's one more question.
Yes, I can see that the time is running out, so I will make it short. So you can see that like there is this burning passion from us doctors, because we see that there is a medical crisis happening right now in this country. But this is what you can only see from us, but not from hospital owners. Like there is, I would say, no incentives at all to prevent hospital overcrowding, because we have a fee-for-service business model. So I think one of the things that we should prioritize, that is to find out how Australia or other countries can apply that fee-for-service model into their medical system. Because, well, if you encourage patients to pay more, then why don't we allow that to happen? Yeah, that's my question.
It's a dynamic. You can allow it to happen, but then what often happens is governments say, and this is all governments of all types, then realise that they can get away with paying less and less, and so they pay less and less, and the patient pays more and more and more. And the effectiveness of the fee-for-service system, if the prices aren't maintained at a realistic level, means that it goes back into becoming a market failure, and only that those who are convinced of the role of primary care and can pay for it, you need both those if the out-of-pocket expenses are great. So there's always going to be tension between the amount the government will pay and the amount that individual people will pay. And there's no answer to that. It's unique to every society. Did that answer your question?
So thank you so much for your answer, Dr. Nguyen and Dr. Hiep and Dr. Sĩ. So right now we don't have enough time, so we can move forward to the session 2 of the seminar. We also serve some small tea breaks outside, so if you want to take a little break, you can go out a little bit, and the seminar just continue. So it's a shorter time. Dạ, kính thưa quý vị đại biểu, do thời gian của chúng ta không có hạn nên là seminar cũng sẽ tiếp tục, nhưng nếu quý vị đại biểu có nhu cầu đi ra ngoài một tí thì chúng tôi cũng có chuẩn bị một số ít tea break ở ngoài, thì quý vị cũng có thể tham dự ạ. Mọi người đi hết. presentation is about quality and safety in emergency care. Xin trân trọng giới thiệu đến quý vị bài phát biểu bài báo cáo của Phó Giáo sư Tiến sĩ Bác sĩ Sally Ann McCarthy với chủ đề chất lượng và an toàn trong cấp cứu.
Thank you very much. It's a great pleasure to be here to talk to all of you today, and particularly hearing the presentations we've just heard about primary care has a lot of resonance, because emergency medicine as a specialty has really only been around for possibly at the longest around 50 or 60 years in some countries. And in the early days, we went through, certainly in Australia and in many countries going through it currently, similar problems that you've just been talking about for primary care. All I can do is congratulate the trailblazers that we've heard from this morning. As Warwick said, your passion is impressive. And I know you'll look back in a couple of decades and think, how did we achieve so much? Because even though it's really difficult at the time, you will persevere. So it's wonderful to hear your presentations. I'm going to talk to you today about quality in emergency care. And this is a particularly relevant topic because after COVID-19, countries became aware of the need to provide excellent quality emergency care, and the deficiencies in systems where emergency care was difficult or inaccessible became very obvious. So the objectives of my presentation today are to talk about what is quality care, look at the impact of poor quality care in emergency care, look at some of the challenges in providing emergency care of good quality, and look at the many resources that are available. Often we think that our problems are very difficult, but then we look around the world and we see that somebody else has already faced the same problem and has often developed a solution that we can customise. So many of you will be familiar with the parameters for, or the domains for quality in healthcare described by the Institute of Medicine in the US a couple of decades ago, which talk about the 6 domains of quality. So first of which is patient safety. So a patient shouldn't be harmed by the care they receive. This harm goes to things not only adverse events, but receiving care that they didn't need, surgery they didn't need, having side effects from medications they didn't need. Effective care, so care is based on best evidence, and both misuse, providing care with no evidence, overuse and underuse all fall into that category. Care has to be patient-centred, so it has to be applicable to the individual patient and to what populations need. So patient preferences, there shouldn't be discrimination in the provision of care. So marginalised communities need to be provided the same standard of high quality care, which may need to be provided in a different way to provide quality care. Care needs to be timely. So reducing delays both from the patient's access to the care they need, but also from the provider's point of view, so that there are often big delays in the systems, wasting providers' time as well, and we often forget about that. Care has to be equitable and not vary in quality based on characteristics such as gender, sexual preference, religion, geographic location, and socio-economic status. And we all want to have an efficient health system where we maximise the outcome for the money we're spending. From the domains of quality has been developed initially the triple aim framework, where We talked about the patient experience of care should be improved. The health of population should be improved by healthcare delivery. And we should deliver that care efficiently, so reducing the per capita cost of healthcare. From this, Triple Aim has developed a focus now on the well-being of the health provider population, and this particularly comes out of COVID again, with many people not having adequate personal protective equipment, or in some nations, violence against healthcare workers. So health worker satisfaction is important, and well-being, and also focusing explicitly on healthcare equity. So we're up to the 5 aims now of a healthcare system. So what is a high-quality system? This is from the Lancet Global Health Commission in 2018. There's some fantastic, I'd recommend anybody interested in health systems and global healthcare have a look at this Lancet series, because it's pretty easy reading but gives a very good overview of some of the issues that we've already talked about today. So a high quality system is one that optimises healthcare in a given context by consistently delivering care that improves or maintains health outcomes. So one of the key words there is consistently. So when a patient encounters the system in a small rural area, they need to be able to be facilitated to get access to the same care that they would if they presented during normal hours to a major tertiary centre, or in a particular hospital. A high standard of care needs to be provided 24 hours a day, 7 days a week. Healthcare system needs to be valued and trusted by all people, so people need to feel safe to come to seek healthcare. That's where equity comes in, so non-discriminatory care, and patients are valued by healthcare workers, and there's trust in the system. And the system needs to evolve. Obviously, if population needs change, as systems evolve, the healthcare delivery needs to change. And again, this is from the Lancet Commission on Global Healthcare. The components of a high-quality health system can be summarised into these 4 components. So systems need to be governed for quality. This is really where the political and government level comes in at the top, but then that devolves down to the governance processes and the policy framework of all, hospitals, healthcare systems, and financial models and outcome measures. This one we haven't talked about yet this morning, but building demand amongst populations for quality health systems is really important in getting change in systems. We were talking outside in the break about, how do we try to change things that are very difficult to change, and one of the ways emergency care has done that is by building awareness in communities and in populations about the value of good emergency care. And that really meant that patient or population education occurred both through forums within the health system and within the government more generally, but also within the media, so that patients and families and communities actually understood the benefits of good emergency care. And I would argue the same thing really needs to happen to get a population support for good primary care as well. Redesigning systems and services. So once we know what we want to do, how is our health system, performing? Do our systems need to change, and how do we do that? So redesign, episodic review of our outcomes for the provision of care for certain diseases, or preventative measures across the population, and tracking outcomes at various levels, and then transforming the health workforce. So these are all very small tasks, as you can see. I'm joking. All of these require a concerted effort and take a long time, but we need to think about them if we're going to actually do them. So all of these are important for a high quality system. What's emergency care? So emergency care has been defined as the delivery of health services for conditions that require rapid intervention to avert death and disability, or for which delays of hours can worsen prognosis or render care less effective. So we see that emergency care sits at the more critical end of the episodic spectrum of healthcare. Primary care fulfills a lot of the acute care needs, and emergency care is when care needs to be delivered for a higher acuity patient or in a facility requiring more resources. And the concept of an emergency care system is really important. It's not enough just to have an emergency department in a hospital or a clinic. One needs to think about emergency care as coming from the point of where the patient experiences the accident or illness, going right through the reception area or the emergency department to operative care or critical care through the hospital, and then back to the community, perhaps with rehabilitation on the way and other services. So it's comprised of pre-hospital and facility-based care, and pre-hospital care often develops after facility-based care in communities, and is something that really has a major impact on what happens with emergency care. And the system is how these services are organised. We have guidance from WHO on what an emergency care system should look like, and over the last sort of 7 years or so, WHO has focused a lot more on emergency care as being a necessary component of healthcare systems. Traditionally, systems weren't really aware of the need to cohort emergency care providers and resources together in an emergency department, or to think about pre-hospital care. And often ambulances within the system were to transport patients between hospitals from facility to facility rather than to be available at the point of care. So the emergency system framework describes bystander knowledge about basic first aid, a universal call number for pre-hospital mobilisation of the ambulance or pre-hospital services, standardised training for first level providers, whether that's the ambulance officer or a paramedic in highly trained and highly developed systems, bringing a patient to an emergency care facility which has got a triage process, and then cohorts patients based on, the triage, has specially trained providers, collaborates with outside and inside the hospital to provide the best care to the patient. So the continuum of communication and collaboration, and then on to critical operative care and downstream. So WHO estimates that conditions sensitive to emergency care, between 40 and 50% of lives could be saved by introducing such a system. It doesn't have to be a highly resourced one, it just has to be well coordinated with trained providers. So when we think about quality care, it's probably easy to look at the impact of poor quality care before we talk about what are the challenges in introducing high quality care. So if we look at the Sustainable Development Goals of the World Health Assembly and WHO, deaths from Sustainable Development Goal conditions due to poor quality care and non-utilisation of care, we see that rapidly provision of poor quality care has become responsible for many avoidable deaths. 20 years ago, it was the challenge of access to care. Now, many populations can access care they need, but the care that they're getting when they access care is not of sufficient quality. It's not evidence-based. People are not properly trained. So these conditions, cardiovascular diseases there being the large one at the top, So the vast majority of deaths due to cardiovascular disease are not due to access now, they're due to poor quality care when the patient accesses care. In low and middle income countries, poor quality care is thought to be a larger barrier to reducing mortality than insufficient access, and 60% of deaths which are amenable to healthcare, or of conditions that are amenable to healthcare, are due now to poor quality care, whereas the remaining are due to lack of access to health systems. So we therefore need to improve our quality. We need to measure what we're doing. You know, how do we know we're actually providing quality care if we don't measure it? And it's not just low and middle income countries. High income countries also have significant variability in the quality of care. And as an example, for emergency care systems throughout Europe, there's no standard provision of emergency care. I think it's something like 14 European countries don't have a specialty of emergency medicine at all yet. The training and curricula vary enormously, and there's no consistent pre-hospital standard. This is through, you know, very high income region of the world. In Australia, we see a disparity between outcomes in rural healthcare and metro healthcare. We see a disparity between certain populations. And this is just a quote from a recent healthcare inquiry which said, strengthening the rural workforce by aligning training and education with local health needs was vital. So back to the need to evolve care depending on what the population needs. So I'm going to address 3 challenges now in providing quality care. One is, how do we get emergency care, and I'm specifically talking about emergency care, how do we prioritise emergency care in our systems? The next one is, what needs to change in health systems, and how are countries going about doing that? And then the third challenge is, what do we measure and what are the outcomes we should be looking at? So people have done, there's been a bit of research done on what are the factors impacting the global priority of emergency care. This has been driven by a number of World Health Assembly resolutions over the last 5 years, which call on nations to prioritise the implementation of emergency care and emergency care systems as an integral part of their health system. However, there's still a gap between that sort of expectation to have an emergency care system and what's actually happening at the ground level. So some of the problems are, there's no clear definition on the scope of emergency care. There's a lack of data on emergency care, who presents for emergency care, who needs it, what are the interventions, what resources are applied to it, and what is the link between system development and development of the training programs, if any. There's lack of credible data for improving outcomes through emergency care often, although that situation's getting better. There's competition with other specialties, and initially the fight for it to be recognised as a legitimate specialty in its own right. And lack of experience in skills and advocacy amongst the sort of trailblazers and the community who wants emergency care. Lack of grassroots organisation engagement, and many other limited sort of inclusion in local policy setting. So these are a lot of factors that have been shown to prevent or delay implementation of emergency care. However, there are now increasingly many opportunities. So WHO has taken on the role of developing a lot of resources, both for clinical providers, for design of systems, design of health services, and also tools on advocacy, and also by their support for resolutions which call upon governments to implement emergency care systems. So, first of all, what's the value of having emergency medicine as a specialisation in medicine? So we know that components of emergency care are amongst the most cost-effective public health interventions. And we also know that if we don't have high-quality emergency care, a proportion of the resources we spend on care at the other end of or downstream essentially are not as efficiently used as they could be. So we've heard about, say, the golden hour of trauma and needing to, address critical patients quickly. That goes more widely across the emergency care system, so that if patients are suffering increasing morbidity from lack of quality emergency care when they need it, they have more complicated illnesses, they stay in hospital longer, they use resources more, there's more mortality, more costs overall to the system. And we know that lack of investment in emergency care is compromising system effectiveness overall and increasing costs in other parts of the system. So I've talked about some of the World Health Assembly resolutions. These are a couple of examples. So in 2019, there was a resolution on emergency care systems for universal health coverage, ensuring timely care for the acutely ill and injured. And then last year, looking at how emergency care itself needs to be integrated across the system. So integrated emergency critical and operative care, or so-called ECO, emergency critical and operative care, for universal health coverage and protection from health emergencies. So this is a real focus of WHO at the moment, and will be driving a lot of changes in countries. There's also been published, and this is definitely worth reading for anybody, including all the primary care passionate people, advocating for change in systems. So WHO has published an advocacy guide. It's freely available on their website. And this is specifically around advancing emergency care, but the techniques and the tools in this manual are useful for any sort of advocacy in health systems. So I'd certainly recommend that to you all. If we look at quality and safety in emergency care, and the impetus of building priorities in systems, we have to look at measuring quality in emergency care. And we'll look at a bit of some of that in a few slides. We have to look at, do we have appropriate standards? So are there accreditation standards for emergency care facilities or services? Do we have training standards? How do we address medico-legal concerns? I mean, this has been a big thing in a number of countries, providers being concerned that they're going to be sued by a patient dying, and so that prevents them from administering emergency care. That's a fix that can be fixed by governments. Some countries have already implemented quality standards or requirements for quality improvements and patient safety measures across training colleges and across emergency facilities. And in countries where emergency medicine is developing, there's immense pressure on the system, and combined with limited resources to address that. So tiers of quality measures need to be appropriate to the system. We all know how difficult it is to measure while providing care. So there are simple metrics we can look at which give an indication that are, able to be collected. So if we look at redesigning health systems, what are some of or redesigning health services, some of the challenges and some of the solutions? Again, back to the WHO emergency care framework. So this is a great sort of baseline for looking at one's emergency care system. And this is really designed for policymakers and health ministries. And it's a consensus-based framework. Multiple countries had input into this, multiple experts. And it assists in identifying gaps in the system so that they can be addressed. If we look at WHO's resource development over the past 5 years, it's really been phenomenal in terms of supporting emergency care. And so as a baseline, the emergency care system assessment, or EXA tool, governments can invite WHO to partner with them to look at their emergency care system and do a gap analysis and look at where best to focus. There's areas targeted for priority action, developing pre-hospital systems. There's a toolkit of standards for pre-hospital systems and training for providers. WHO's developed some quality improvement standards for both trauma and emergency patients. WHO's developed quite a number of courses now, and I know some of those courses are being rolled out here in Vietnam, like the Basic Emergency Care course, which is designed for all providers, not just doctors, as a way to get the basic standard of knowledge about emergency care elevated in a short period of time. There's basic tools which have been agreed, and formal triage and other protocols. Again, I know they've been implemented in Vietnam. Countries often take these tools and customise them locally, which is absolutely fine. That's what they're designed for. But there needs to be an overall legislative, if you like, framework to guide all this implementation and to enable implementation. And WHO, again, has got a list of policy tools to support that process. All of these are available on its website. This is a list of some of the tools for emergency care. Is anyone familiar with these tools, the WHO tools for emergency care? I think I can see some heads nodding there, but those of you who work in emergency care, I'm sure will be. They're, really quite copious now, and WHO also has an online academy. So a lot of these courses, not all of the courses, some require face-to-face, but some of them are available online and can be signed up to by anybody. So in terms of changing systems, so some of the research from various African countries shows that some of the challenges recur again and again. So this looked at challenges and triumphs in Ethiopia in introducing an emergency care system. And so one of the key challenges for them was all providers needing specialised training. And the WHO basic emergency course goes some way to bridging that gap. There's lack of support from other specialties. We heard that this morning in primary care. This is a worldwide phenomenon. Lack of a pre-hospital ambulance service and utilisation, so it's not coordinated. There isn't one. There's no universal access number. Providers aren't trained. They're volunteers only. And lack of equipment and essential drugs. Another thing WHO's got global experts to do is sit down and create a standardised medication equipment resources for different levels of emergency care facilities. So they're worth a look as well as somewhere to start for changing your system. And then looking at what are the priority research questions. Where do we need more information about emergency care? So this again was a global initiative to look at the key questions. So the priority research questions were thought to be for emergency care indicators, looking at the accuracy and the impact of triage tools. So is triage occurring according to evidence-based guidelines? What is the impact of emergency care registries? What's the epidemiology of people seeking emergency care? What are the best practices for staff training and retention? And looking at costs and cost effectiveness of various interventions. So these are fairly sort of standard questions in every system. Another study looked at the actual development of indicators and implementing these in a number of African countries. So clearly indicators need to represent conditions that occurred frequently, fall within the scope of emergency care. You can improve the outcome of the patient if you implement the initiative, and depend on currently available diagnostic tests or equipment, currently available therapeutics are feasible to collect and are applicable to the current reality of emergency care, in this case in Africa, but I think that goes for all systems. So they decided mortality from trauma, mortality from lower respiratory tract infection in adults and children, mortality from asthma, or patients who left without being seen and didn't wait for care. So it's a limited suite of indicators, but address some of the major problems in their context. Clearly for Vietnam or for Australia, these particular topic areas might be slightly different, but again, it just shows they're fairly simple and they can give information about the system. If we look at what individual providers want, the International Federation for Emergency Medicine did a survey, or does a survey every couple of years globally of emergency care providers. And we see that both system income levels, so low and middle income level and high income level countries, wanted quite similar things. In low and middle income nations, education was a key desire. There wasn't enough easy provision of emergency care education. Benchmarking and improving quality of care was important. Guidance and advocacy in strengthening emergency care and developing the specialty. So we see they're at an earlier level of implementation of the specialty, with a desire for a resource library and training resources which were accessible and authoritative guidance. High-income countries also wanted advocacy. They wanted to be able to engage directly with government. So providers wanted to have a mechanism to actually tell governments what they thought they should be doing, or what they could do to improve the system. Good leadership was important, and partnership and collaborating globally. I think this is very important because, as I said, somebody's usually developed the tool or the solution that you want. And again, authoritative guidance. It makes it much easier to change systems if we can point to something and say, this is the standard. We know we have to implement this because this authority has said that this is what we have to do. It cuts out a lot of argument at the local and the hospital level. So this has worked really well in Australia. So just to look at now what to measure and how to monitor and improve quality, I'll just quickly run through a selection of different things. It's really just to give you a taste of the resources that are available. So the International Federation for Emergency Medicine has published frameworks on quality and safety in emergency medicine, and it was recently updated. That's available on their website. And it's a fairly simple framework, which is applicable broadly. There's some excellent documents from the Australasian College for Emergency Medicine in Australia and New Zealand, looking at quality standards for emergency departments and hospital-based emergency care services. So this is from the smallest first level clinic up to the most sophisticated tertiary level hospital, looking at what are the quality standards. And so whilst they offer aspirational criteria, over time these standards have actually pushed higher quality in Australia and New Zealand. That document comes with a toolkit, which is online, it's freely accessible. It enables anybody to look up particular areas of those domains, look at what are the standards, what are the objectives, and what are the criteria we need to meet to be providing a quality service in that area. Just going to give one example. It looks quite complicated when I'm showing it to you, but if you have a look at the resource, it's pretty simple. There's just a lot of different sub-points under the domains. So this is a domain of, in the pink there, of clinical care patient pathway. So the important things for quality care in that are things like communication with the patient, pre-hospital care, arrival, what happens when the patient comes to the emergency, how they're assessed, and by whom, a care plan that all providers can follow so the person gets seamless care. How's that plan implemented? How's care handed over? I mean, we talk about handing over within the hospital, but, hand over to the GP when they go home, hand over to critical care, hand over to the next hospital if they need transfer. Are there special consideration for particular groups of patients? Do paediatric patients need purpose-built areas, or geriatric patients, etc.? What about care of the dying person? This is a group we're seeing more frequently in emergency departments. Many systems, still haven't caught up with the epidemic of non-communicable disease and the end-of-life care that we need to. So a lot of patients at end of life come to emergency. And what about virtual care? So the domains of quality under this toolkit looks at the various things that we need to address, you know, those particular domains. So professionalism is one, education and training, research. If we look under all of those, there are particular metrics we need to look at. And at the bottom line, looking at objectives. So, you know, this looks at education and training. So, you know, each of these is a component of how we know we're providing quality training to providers. So it sounds complicated, but we need to look at these things to know we're actually making the best use of time that we have to provide education. That's just one example. And it looks at the criteria. So, okay, we know what objectives we have. How do we meet them? What do we need to meet those objectives? So these are some of the inputs there. And there's various case studies. For example, the top one there is reducing lengths of stay for high dependency patients in the ED, and all the sort of things that are evidence-based for doing that, etc. Faster pain relief. If we look at the individual physician and nurse leader level, the Royal College of Emergency Medicine in the UK has got an excellent book toolkit which is available online, which is an introduction to quality improvement, to some of the techniques, some of the basic science of QI. So that's worth a look from the individual perspective. Back to WHO. WHO has now launched the Clinical Registry Emergency Care, and the Trauma Care Registry has been around for a couple of years. And this enables people to put in information on their smartphone about patients they're seeing using WHO checklists and protocols, and then look at the collated data and look at how their department or hospital or group of hospitals is going. It arises from World Health Assembly resolutions, all of which call for measurement and collection of data. Because that was difficult, WHO developed a software system which is freely available to any country or provider who wants to use it. And so one just has to register. So the Clinical Registry for Emergency Care was developed in 2022, and it has the potential to significantly improve emergency care under some of the very basic parameters for care of the acutely ill and injured. There was a pilot last year. I led the pilot. It was in 7 global EDs in those countries. And you can see that many of those are very sort of poorly resourced emergency care facilities, but nevertheless, they did manage to complete the registry and found out some useful information, and that is available for rollout. These are some of the standardised forms on the WHO website. So these are often useful when your providers are not highly trained. You know, they can use these as a prompting checklist to prevent missing important components of care. The yellow highlighted sections of the variables found in the registry, so they mirror the form that can be used in the emergency department. The platform can give graphs and monitor, you know, month by month or whatever, or it can be just collected, say, over a weekend to look at how a unit is going. Dashboards can be available at all levels, looking at a whole system, looking at a group of hospitals, looking within a department. There's audit filters, so, you know, did we put in a chest tube if the patient was hypoxic? Did we give IV fluids and resuscitate someone with hypotension? Did we check the blood sugar on somebody who was unconscious? So pretty basic sorts of things, looking at all deaths. So these are all useful audit filters which one can use for quality improvement programs in one's own department. And the data visualisations, as I said, can be at various levels. So at a government level, at a state level, system level, department level. And so in conclusion, there is a pressing need to measure the quality of care that we deliver. Further implementation and development of emergency care as a specialty should be prioritised, and development of emergency care systems. Redesign of health systems will enhance health system performance. That's easy to say, hard to do, but there are some tools that I've shown you that support that. And there are many excellent tools and resources supporting good emergency care. And if you haven't developed it yet, just look somewhere else. Someone else will have, and you can just, share it from them and just customise it to your local site. So thank you very much.
Alo, xin trân trọng cảm ơn Phó Giáo sư Tiến sĩ Bác sĩ Sally Ann McCarthy. Thank you so much, Associate Professor Dr. Sally Ann McCarthy. And to continue the program, I would like to invite Associate Professor Dr. Anthony Philip Joseph, Lecturer of Faculty of Medicine, University of Sydney, Australia, to report the topic optimal management of the geriatric trauma patients. Please welcome.
Thank you very much. And thanks to the Phạm Ngọc Thạch University for inviting us to talk today, along with the Hochmeier Foundation. So I'm going to talk about trauma in the geriatric population and what's the current best practice. So the aims are to understand why older people are more prone to injuring themselves, to look at some of the causes of injury in the older population, to look at some of the tools we can evaluate and identify geriatric trauma, and how we can actually better care for these patients in the emergency department. It's a busy slide, but the world's population is getting older. Look on the left there, you can see Vietnam, long country, 100 million people, and 8% of the population in this country, or 8 million people, is over the age of 65. Currently, 10% of the world's population is over the age of 65, but it's going to increase to 1 in 4, 25% by the year 2010. And the only areas where the population will be younger in 2010 is Africa. So what's the problem? In high-income countries, we're seeing more and more older patients come in, mostly with falls. Look at some of the Australian data from the Australian New Zealand Trauma Registry. 26% of the older population admitted in 21-22 were over the age of 70. The mechanisms of injury were mostly falls, 71%, and transport-related, 21%. This group had a high mortality, around 25%, compared to the overall mortality for the trauma group of about 9%. And the older population did tend to stay longer and have more complications. So there are some issues with defining what's elderly. Is it age 55 and older? Is it 65 or is it 70? We tend to now, in our country, is defining older as 70 because we're seeing so many fit 65-year-olds come in that, but once they reach 70, they start to get a bit more frail, and I'll talk a bit about that later. The Advanced Trauma Life Support course from the US defines older trauma patients greater than 55, and they use that tool to direct older patients to trauma centres. But there's no real consensus on what defines geriatric. And maybe we need to start thinking more about physiological versus chronological ageing. I'll explain a bit about that. Older patients have different mechanisms and patterns of injury. They tend to fall over more often, as I said. They have a more severe response to an injury, particularly if they're frail, because the definition of frailty is a lack of homogeneous response to a stressor. So if you're frail and you injure yourself, you don't tend to bounce back as well. There can be delayed presentations. The outcomes are worse, as I said. The costs of care are higher because these patients stay in hospital longer and they have high rates of complications. And you need special knowledge and skills to deal with this population. And the estimate from high-income countries is that geriatric trauma costs about 1/3 of the cost of all money spent on caring for injured patients. If you look here, the trajectory of ageing, most of us want to be in this situation here where your physiological reserve decreases as you get older. But if you're frail, you get an accelerated decrease in your physiological reserve. And once you get to this level here, you become frail and you get sarcopenia. Sarcopenia means you lose your muscle mass and strength. And that's something I've noticed as I get older, and not to mention the cognitive decline as well. So you've actually got to think a bit about that and work out ways you can mitigate against that. When you get down to this area, you finally get disabled and lose your independence. So you don't really want to get to there, otherwise you end up in the nursing home. There's an epidemic in the UK about older people engaging in dangerous activities. They race their four-wheel drives, or they engage in dangerous exercise like yoga, and they can fall over and hurt themselves. So what are the causes of trauma in the older population? Well, as I said, we're more active, but unfortunately, as you get older, your sight and your hearing decreases, there's slower reaction times. As those of you who are a bit older, and probably not many of you are older than me in the room, but that's all right, you have problems with your gait and your balance. As I said, you get sarcopenia, where your muscles waste away. You get degenerative joint disease, and also get neuromuscular disorders as well, not to mention motor and cognitive dysfunction as well. So all this is sort of conspires against the older population to do well when they injure themselves. So some of the key points from the Australian College of Surgeons, Geriatric Trauma Management, they focused on falls prevention, a tailored approach to addressing injured older patients, and particularly interdisciplinary approach. So if you have an older patient who's frail, comes into hospital, then not only the trauma team should look after them, but the geriatricians need to get involved as well, because if you can actually optimise the initial care, these patients tend to do better. And we emphasis on gentle care, or primum nocere, first do no harm. So if we look at older patients when they come in pre-hospitally, they're under triaged quite often because people that look at them say, "I'm not that unwell." So the common triage tools can be misleading. Often we think they've had a simple fall, but they can actually have lots of serious underlying injuries. The vital signs may not be a good guide as to how acutely unwell they are, and the injury severity score is late, so we probably can't use that. The Americans use CRAMS, looking at circulation, respiratory effort, abdomen, motor and speech, and the trauma scores. A whole lot of pre-hospital tools you can use. So what are the activation for a geriatric trauma call? So if an older person falls and they're on blood thinning medication, then they should have a trauma call. If they're hypotensive, systolic blood pressure less than 110. If they're tachycardic, greater than 90. If their shock index is greater than 1, so their heart rate over their systolic blood pressure is greater than 1. Or if they have a ground level fall, but not on anticoagulants, but with a low GCS, so they may have head trauma. So what about geriatric trauma admissions? Well, most of these are due to falls, as I said previously, about 80%. And when they fall, they injure their have hip fractures. Rib fractures is very common, and also brain injuries. I read today where one of our icons in Australia, a woman called Maggie Bear, who's 79, who's a well-known chef, had a fall the other day at her home, and she was reasonably fit, and she had multiple injuries from a simple fall, and that actually hit the Australian national news. So this reflects, I guess, our news. Maybe we don't have a whole lot of political stuff to report, I don't know. Falls are the number one cause of injury. As I said, responsible for more than 50% of the injured older patients arriving in hospital. And an interesting fact is 30% of patients over the age of 65 have at least one fall every year. And 10% of those falls can lead to major injury. As I said, the injuries are fractures or brain injury. So when we look at the causes of falls in the older patients, 1/4 of them are due to underlying medical problems, so such as syncope. They may be hypovolemic, they could be dehydrated, could have gastrointestinal infection, could have other infection, could be medication related, particularly antihypertensives. There could be elder abuse, and there's a thing called the San Francisco syncope rule, which I'll talk a bit about. But if you have a quick look at falls prevention here, it's a whole lot of issues that you can engage on to stop older people or mitigate against older people falling over. And the one I'm particularly interested in is this work in the gym. You know, you need to get in there and actually strengthen those muscles, particularly those proximal muscles, strengthen the balance, and this actually can mitigate against falls. The other thing is you can make your home safe by putting rails on the stairs, putting rails in the bathroom, etc., and a whole lot of other simple things, making sure your carpets are flat and you don't trip over them. Of course, older people don't tend to lift their feet up as well, etc. So a whole lot of things you can do to prevent falls. The San Francisco syncope rule, I apologise if you've heard this, but I like it because it's got a fairly simple mnemonic, the chest mnemonic. C for congestive heart failure, H for hematocrit less than 30%, ECG abnormalities, S for shortness of breath, or S for systolic blood pressure less than 90. To have any of those 5 conditions, they probably need to come to the hospital and be investigated further. Motor vehicle accidents, as I said before, they form a minority of the mechanisms for older people coming to hospital, between 20 to 40%. They're more likely to occur during the daytime, often close to home, within 3 to 5 kilometres of the home if they're driving, or at an intersection, and it often involves 2 cars. Airbags can cause a problem because your ribs and sternum are very malleable and can fracture easily with the airbags. And interestingly, less likely due to alcohol or reckless driving or excess speed, just maybe inattention. And then pedestrian accidents are quite common amongst older patients as well. They're the second largest group after children, and they're often likely to be seriously injured even with a low speed pedestrian accident because of all the other things I spoke about, particularly osteoporosis, etc. And they have a high mortality. Just briefly, some of the physiological changes in ageing, they're very similar to the changes that occur in acute exercise, except acute exercise can actually strengthen your muscles, ageing may or may not. But you get cognitive disorders, you get high systolic blood pressure, increased work of cardiac work, increased cortisol activity, poor response to stress with increased reactive oxygen species, poor mitochondrial function and muscular strength, and just decreases muscle breakdown and osteoporosis. So unfortunately there's no good news for getting older. So we talk about cardiovascular response. Older patients have an exaggerated response to cold, hypoxia and acidosis. They have less response to circulating catecholamines. So if you give older people who come in shocked inotropes like adrenaline or adrenaline, don't tend to respond all that well to it because of the cardiovascular musculature decay. And hypovolemia, they often compensate by increased systemic vascular resistance rather than increased cardiac output. And often they've got underlying coronary arteries as well. So if you come in shocked, if you're older, you're going to have a poor prognosis because your capacity to adapt is not as good as younger people. Respiratory system, our lung function is decreasing, our vital capacity, loss of compliance on the chest wall, we're osteoporosis, so our ribs tend to fracture and sternum fracture easier. We get weakened intercostal accessory muscles, so we get poor respiratory effort if we have an underlying chest injury. And as I said, for all those, we get rib fractures, etc. The brain, subdurals are more common in older people who hit the head rather than epidurals. Epidurals are actually rare, in fact, and often they're on medications such as blood thinners, oral anticoagulants, which can conspire to cause intracerebral hemorrhage as well as subarachnoid hemorrhage. Cervical spine, older people, when they fall into their upper cervical spine more commonly because it's more fixed, and often got arthritis in the joint spaces, so they tend to get central cord syndrome more commonly. You can see an evidence of some spinal cord contusion there on that MRI, and mortality of cervical spine injury is quite high, about 26%. Hip fractures, older people fall over. Actually, there's a surprisingly high mortality from hip fractures, up to 30% in the first year, and often can present subtle ways. They may be able to weight bear or may have just pain on weight bearing. Older people often on lots of pharmacy, lots of drugs, and one of the criteria for frailty is if you're on 5 or more medications. And interestingly, there's a 14% increase in falls for every medication over the number of 4. Have they started a new medication, or do we need to start another one when they come in? So what are the assessments, takeaways in the emergency department for older patients who injure themselves? You need to work out what happened before the injury, what medications are on, what's their underlying injury status, have they got any cardiac problems, any cerebrovascular problems. You need to also think about developing some comprehensive geriatric trauma pathways that can extend into the patient's hospital stay, which can actually improve their length of stay and their outcomes. And this study here looked at the early ambulation, delivering non-pharmacological medications which are going to make people less drowsy, look after their bowel and their pain, ensure close attention to the nutrition, get your physiotherapists involved early, and a comprehensive geriatric assessment. And if they did all this when these injured patients came in, they found that there was actually less complications and less readmissions within 30 days. So what they found, this particular group found, was that you get improved outcomes in geriatric trauma if you get patients out of bed early, if you try and prevent delirium with non-pharmacological approaches like quiet environment, not too much stimulation, stop constipation, treat their pain, adequate nutrition, physio and geriatric assessment. What we also know is the frailty leads to more inpatient complications, and frail patients actually in this study had increased rates of sepsis, deep vein thrombosis, pneumonia, increased length of stay, and poor discharge destination, not home to nursing home or rehab facility. And what we know here is that if you're frail and from this study, frailty and increasing age over the age of 75 led to worse in-hospital complications. I retired from clinical practice recently, but before I did, we were completing a study on older patients who came into our hospital. It was actually a 3-hospital study where we looked at the prevalence of frailty in trauma patients who are aged over 70 and its implications for outcomes after major trauma. And was my hospital in Sydney, North Shore, and also Royal Adelaide Hospital and the Gold Coast University Hospital. And it's currently in the process of being considered for publication. But just to briefly summarise, when we measured frailty when these patients came in, and there's a whole lot of tools you can use to measure frailty, but we used a tool called the Reported Edmonton Frail Scale. And we had roughly half, had over 200 patients in the study, half frail, half non-frail. We found there was no increased risk of death in frail patients during the initial admission, but there are significant associations at 3 and 6 and 12 months if you're frail with falls, confusion, readmission to hospital at 6 months, increasing level of dependency, so ADLs and IADLs, you might more likely end up in a nursing home. But the important thing we found was the increased risk of death at 3 months, and that increased by a factor of 5, and at 6 months increased by a factor of 15. So frailty in this study was actually a very important determinant of how you're going to do if you're older and you're coming to hospital. There's a term called the frailty-specific pathways, and if you can identify a frail patient when they're coming to hospital, if you can implement this frailty-specific pathway, this can actually improve their outcomes. So early hospitalist consultation or generalist consultation to assess their general medical needs. You need to talk to the family early about what the likely outcome is going to be, particularly if they're frail, how long they're going to stay, what their discharge destination is going to be if they get out of hospital. You need to engage palliative care if you think that actually there's a good chance they might die in hospital. You need to improve or get increased access with social work, physiotherapy and occupational therapy early. And then there's also the concept of a specialised order form, the admission order form, which helps clinicians decide not to give them medications which are going to make them drowsy, more likely to fall or get confused while in hospital. And that is shown to increase the better the outcomes for these patients in hospital. So, as a result of our study, we thought that all trauma centres should add a frailty assessment to the initial assessment of older patients when they come into hospital, and your definition of older, 65 or 70. Our data suggests that frail patients have worse outcomes at 3, 6 and 12 months. I'm not sure if you're aware of this book by Gundi, Being Normal. I'd recommend strongly that you read it because just the final thing, doctors were far more willing to recognise the signs of defeat and less arrogant about denying them. So in other words, asking people to be more realistic about their expectations. So in summary, when you're dealing with geriatric trauma, we need to expand some of the geriatric-specific trauma guidelines to identify older patients with serious injury. When we activate the trauma team, we need to think about underlying causes for the injury, particularly the fall, and recognise that these patients may have altered vital signs and also altered patterns of injury. And in hospital, you should try and instigate some degree of frailty screening, which includes a dementia screen, and then instigate specific frailty pathways which can improve outcomes for these older patients. Thanks to one of my colleagues, Erin Simon from the Cleveland Clinic, who was part of the trauma special interest group for IFM, who helped me with some of this talk. And that's it. Thank you very much.
Thank you very much, Associate Professor Dr. Anthony Philip Joseph. Và tiếp theo đây xin trân trọng kính mời Thạc sĩ bác sĩ Nguyễn Hồng Trường, giảng viên bộ môn hồi sức cấp cứu chống độc trường Đại học Y khoa Phạm Ngọc Thạch, báo cáo chủ đề đào tạo và thực hành cấp cứu tại Việt Nam. Xin trân trọng kính mời thầy. Next, I would like to invite Dr. Nguyễn Hồng Trường, Lecturer of Emergency and Anti-Toxic Department, to report the topic Education and Practice of Emergency Medicine in Vietnam. Please welcome.
Dear everyone, it's so happy to talk about the last presentation. So, I have been Australia sometimes for studying. I've been the Alfred Hospital in Melbourne and the Flinders University in the Adelaide. I'm so impressive about the healthcare system. When I was there, the first time I saw the hospital with a different gate for the patient. The gate for trauma, the gate for poison, and the gate for usual care. In Vietnam, only one gate. Beside the gate, you can see many shopping on the street near the hospital. Yeah. And but one thing made me unhappy. I almost lost my staff for Australia country. Yeah, my emergency doctor. Okay. So now I would like to talk about the emergency care, education and practice in Vietnam. About the curriculum, some challenges, and a few change. So 20 years ago, I, similar to another old medical student in Vietnam, I spent 6 years in medical school. During that time, I would say that the medical student only study 4 lessons, official 4 lessons in the emergency medicine. I can say that that were approach to shock, approach to the respiratory failure, acid-base disorder, electrolyte disturbances. That's all, only 4. But the student can study at another subject, for example, internal medicine, surgical medicine, some lessons similar to the emergency. After 6 years, the junior doctor had to go to the hospital and did around the hospital round. Depend on the policy, maybe 12 months or 18 months. After that times, they fill the paperwork, collect own documents and submit to the Department of Health. And they get a license from the Department of Health at the GP. 6 years, 12 months, and 7 months for the license. Since now they can work as the real doctor, GB. But it's not the simple GB. The GB in Vietnam can work in the specialized department. For example, they can work in the emergency department, even in ICU department, as the junior doctors. For me, I also work there, ICU department. After 12 months of the practice in the ED or ICU, they can apply for the higher level of the education. We call the level 1 education. But they don't divide into the different curriculum for the emergency medicine and for the intensive critical care medicine. They use the same curriculum. It takes 2 years for the level 1 education. And my faculty is the emergency critical care medicine and toxicology. For me, at that time, I didn't study that specialty. I studied clinical pharmacology, the basic science. Okay. Yeah, because I think that the basic knowledge is more important than this one. Okay. Many people ask me, but I cannot answer why. So now, for the emergency department, the GB junior doctor working at the department, they receive the patient, come to the ED, but they approach the patient like the cut point. They don't know what happened before, pre-hospital, and they don't care after ICU, rehab, home care. They don't know, and they don't care. They approach at the cut point. No knowledge about the system of care, no knowledge and skill about some basic life support, ACOS, pulse, trauma life support. They do as the common sense. Yeah. That's the problem. And they approach the patient based on the traditional approach, no systemic approach, no ABCDE approach. They try to do head to toes approach, but for emergency case, couldn't do that. So now, that's what we did here now in the clinical practice. In the ICU, even worse. For me, I work in the ICU department without any knowledge and skill related to the emergency care and ICU care. Just junior doctor, GB. So in Vietnam, we divide into 2 levels of the specialty, 2 years for level 1 and next 2 years for level 2. But in the ICU and emergency department, only few doctors reach the level 2. Most of them just level 1. So I worked in the ICU department for 4 or 5 years. I was so disappointed because no matter what, I work for my patient. The mortality rate is so high. I don't have the exactly number, but I can guess 90%. I think so. Was very disappointing. I didn't know what to do for a patient at that time, so I gave up. I'm quit. I ran away from the Ho Chi Minh City. I moved to another province, very far from here, and I work in the rural hospital, like the retired doctor. But lucky, at that hospital is very, very small. So I receive patient from the beginning to the end. I have the whole picture for the patient. And I recognize my gap of this understanding. After just 1 year working there, I get back. I back to the Ho Chi Minh City, but I choose the rural hospital, not the central hospital. The rural hospital is very small as well. Emergency department have 10 beds, but only 5 of them have a trap. 5 still empty. I received 6 junior doctors. I only have 1 monitor, 1 defib, 1 EKG. That's all. That's what I got in the rural hospital. So I trained my staff slowly in the emergency approach. I invited some team from US, from Australia come to us and teach us. They learn a lot. They learned this guy from the Utah University. We learned bogus since then. We learned trauma, many things. For me, I try to become the HA instructor. When the HA organized the class here, I came there by myself, not official. I sit behind and try to study everything. They want to get me out, but okay, allow me to join. Okay. After several years, they accept me as an instructor. Okay. So I apply this knowledge and skill to all my staff, and something changed. Again, I moved to another hospital, centrally, but still the district level hospital, level 2. You know that in Ho Chi Minh City, level 1 is higher than level 2. Yeah. But I have more experience already. I think that the ICU doctor need to learn emergency initially. No emergency, no work. So I asked my staff to get the certificate from IFAM. Yeah. Now in that school, we try to apply the basic emergency care from WHO for the education, but the book was rejected already because some powerful people say that this look very simple. So I'm failed. Now something changed. This is my education curriculum in the school. Before only 1 credit. So now 2 credit for 6 years medical student in emergency medicine. But it's not mandatory, it's just optional. The medical student can choose study or not. Now here's the list of the topics we try to put on the medical student brain. And I hope that they can apply somehow, can save the life, at least. Yeah. The lucky information in Vietnam is the emergency department now is the independent department. Before we don't have that. Before in the emergency care, we used the doctor from another department come to the ED to work together. But now we have our own team for the emergency and ICU. Here is my team in the ICU district level hospital. And the awareness about the emergency medicine is increasing. We cannot do the official training here, the official curriculum here, but we can send my team and do the education remotely. I'm the teacher, but I'm also the driver, the doctor, delivery. I brought my equipment, mannequin, ventilator, motor to anywhere, all over the countries. And we do the training there. Yeah. Scoop, stretcher, everything. Splint. Yeah. And another thing, another news, several hospitals in Vietnam try to follow the international standard, especially in the stroke, acute coronary syndrome, and the trauma brain injury is also good. Yeah, I think that we will be improved later. Yeah. Okay, finally, we are still the low-income country. Someone say middle-income country. There are many challenges, but I'm still alive in that area. And I hope that we can apply slowly the basic knowledge and skill in that school first. And then in the near future, we have a full curriculum for emergency and critical care medicine in Vietnam. Thank you.
Xin trân trọng cảm ơn Thạc sĩ bác sĩ Nguyễn Hùng Trường. Và tiếp sau đây thì hội thảo của chúng ta sẽ đi đến phần thảo luận phiên thứ 2. Thì không biết là quý vị đại biểu có câu hỏi nào để đặt ra cho các báo cáo viên trong phiên thứ 2 không ạ? And now we move to the discussion of the session 2. So if you have any questions to our speakers, please tell us.
I really want to ask that what are the most significant challenges facing for emergency qualities and in Australia? Thank you.
Thank you. I think there are a number of challenges which relate to some of the topics I think that most speakers this morning have mentioned. One is consistent levels of training. So, as we know, emergency care has to be provided 24 hours a day, 7 days a week, and we seek to provide consistent care no matter where that care is provided. And so it still remains difficult, even in a very wealthy country with, a long history of good medical training like Australia, to make sure that individual doctors have got the experience and training they need. So that's one constant challenge, which we've come some way to meeting, but it's still a challenge. Another one is overcrowding in emergency departments, and that relates to principally the ageing of our population and people having exacerbations of chronic illness and the need for increasing hospitalisation of people even ahead of population growth. So older patients with complex conditions stay longer in hospital, and so then people coming to emergency departments who need to stay in hospital can't access the hospital bed in a good time frame. I think the other thing we have is there seems to be within a population perhaps different expectation around our community in terms of using basic self-care for minor emergencies, and also expectations about what modern medicine can provide. So sometimes we see that community expectation may at times be a bit unrealistic, meaning people might present for emergency care when the condition might not be best treated in an emergency department. So really around training the ageing population and the need to change our system to better service that need of older patients. And also we need to have better conversations with communities about their healthcare in general. But I think when we talk about emergency care reflects what's going on in the healthcare system.
Tony, you said that after a major trauma such as a hip fracture, the mortality at 3 months was 5 times greater than the elderly patients, 5 times greater at 3 months, 6 months, 15 times greater. I would have thought as the longer after a trauma, the mortality rate would have been less. That's the first thing. And what were the causes of death in the groups as time went on?
Thanks, Chris. I think you're referring to the frailty study. So what we found that with frail patients, when they came in, there was no increased risk of death or adverse complications in the initial admission. But 3 months after the injury, they had a 5 times increased rate of death as opposed to non-frail patients. But we didn't know the cause of death. All we knew was they died. And at 6 months, there was 15 times. Again, the numbers were small, but they were significant compared to non-frail patients. There were no deaths at 12 months, and the reason we figured that was because if you were going to die, you probably would have died in the first 6 months after injury. But we didn't actually find out the cause of death, and all we knew was they died, and the numbers were small. So whether or not it was directly attributed to frailty or other conditions, it's hard to know, but all we know is frailty was associated with that increased risk of death. So I guess that what we took away from that, I mean, with the other things like increased risk of complications, the increased risk of falls, increased risk of delirium, increased risk of readmission to hospital at 6 months, not at 3 months and 12 months, but at 6 months. So all those things, what we're deducing is that if you're frail and you're older and you injure yourself, your risk of something bad happening is increased by a factor of between 5 to 15 if you're talking about death, but other injury, I don't know the actual multiplication factor for the other factors like delirium, but I think it's just a way of actually having a discussion with the patient and their family about the possible outcomes. Because I think that what we're seeing is that we don't want people to be engaging in treatments which are going to be futile or actually do further harm to the patient. So it's just a way of actually engaging with the patients to actually look at a better outcome for older patients when they come into hospital. Having said that, if you're not frail and you're coming and you injure yourself, you're going to do as well as a younger patient if you're older. So frailty seems to be the rate limit, the determining step.
I'd like to ask a question to Dr. Trong about emergency medicine education. I know there's a Vietnamese Society for Emergency Medicine. Is there, and you may have answered this question in your talk, but I just wondered, is there a standardised curriculum across the country for emergency medicine education? And is there much networking amongst emergency physicians and trainees in Vietnam?
So I can introduce, I also the Vice Secretary of the Emergency Association in Vietnam. Yeah. So I just joined the Congress, National Congress yesterday in Da Nang about the emergency in medicine. We, as I would say, that the awareness increasing. That's why we have that association. That one just established for 5 or longer a little bit years in Vietnam, and I'm a first vice secretary. So we try to apply the training here. Some of the university, they have a more powerful to do that. For example, in the north, they have the residency curriculum, and it's look better than in the south. Yeah, and in the south still low. Yeah, and I think that many doctor physician recognize the emergency medicine is getting more important. You know? So the network is bigger now. Okay.
I'd comment that the international, and I'm sure you're aware of this already, but the International Federation for Emergency Medicine has consensus curricula for undergraduates, postgraduate specialty training, and then training in paediatric emergency medicine and in other aspects of emergency care on its website. So there's some good resources there that people can easily adopt. So.
I have three questions. The first question is about are there the program education for family member, emergency education program? Okay. The second is you just give some website. It's a free website and free download. Yes. Okay. And the third question for geriatric, and how about the purchase in nursing home in your country? Nursing home, your country, the budget, money. Yes, budget. Yes. Thank you.
Community members. Australia has very widespread programs for basic life support training for public responders. Schools do it, community sports clubs, surf life-saving clubs, community organisations provide the training. Any individual can seek training in basic response to emergencies such as cardiac arrest, drowning, foreign body aspiration, a seizure, many other simple bystander interventions. So yeah, those programs are really well established, and in fact, my hospital is in a coastal area in Sydney, and we find that the bystander response is actually excellent, and we've seen that improve, over the last couple of decades because people do that training.
Just, hang on, just get out of here for a minute. Just with the nursing home, I think the first thing is try to avoid going into a nursing home. So I think that on a serious note, one of the take-home messages we found from doing this study was when the reviewers' comments came in, they said what were we doing to prevent frailty, and we weren't doing anything, but we had to start thinking about that. As you identify a frail patient or a pre-frail patient who comes into hospital, then you can actually educate the patient to actually start things like nutrition, like exercise, like cognition, like balance, etc., to actually avoid getting frail, to avoid getting in the nursing home. Because you saw from my first graph, natural process of ageing is your function goes down linearly, but if you're frail, it goes down quickly. So you need to avoid that. Just coming to your question about nursing home, in Australia, there's a variety of nursing homes, for-profit and non-for-profit, and depends on the money sometimes, how much, and the availability. We don't have enough nursing home beds at the moment because often in hospital in Australia, older patients who can't go home because something's happened, they've had an injury or whatever, and they can't mobilise, they need nursing home care, may wait 2, 3, 4 weeks for a nursing home bed. So there aren't enough beds, and the government is now introducing a factor that the more assets you own, you need to pay more for your nursing home care, which I think is reasonable. And also we're looking at the quality of the nursing home care, because often the nurses in the nursing home were not, some of them skilled nurses, but some nursing aides with limited nursing experience. So they're trying to attract more people to work in nursing homes by paying them more money, so they actually get a better quality of nursing care. And I think also the thing that we need to look at in our country is providing better medical and nursing care in nursing homes, so that patients actually don't need to leave the nursing home unless something happens, where hospital will definitely provide an advantage. If you fall over and break your hip in the nursing home, then you should go to hospital and get that fixed. But if you have pneumonia and you're 90, then that may be nature's way of exiting this life, you know. So I think we need to have more of a discussion about the process of accessing care if it needs to happen in nursing homes. So I'm not sure if that answers your question, but it's complex. And I think overall we have a pretty good nursing home care system in Australia. It's expensive to run, but we recognise that, and people with more money will pay more for it in the future. Okay.
One question about your study. So, according to your study, you said that there is a 14% of increase in falls for every medication over 4. So, does that also count vitamins or minerals, supplements? And do those drugs fall into the same category, like cardiac medicine or diabetic medicine, or?
Yeah. Look, I don't know the details of that study, but from the other literature I've read, it's probably related to cardiac active, like antihypertensive medication, anti-coronary, ischemic coronary artery disease medication, blood thinners, etc. You know, so I think it's more medication which are more active on your cardiovascular system and your central nervous system. But having said that, if you're taking calcium and vitamin D medication, probably means you've got osteoporosis, so you may have increased risk of having a fracture when you fall. But I think that when they looked at it, they just looked at the overall number of medications, but I don't know the breakdown of the medication. But often if you're taking 4 or 5 medication, there's going to be 1 or 2 antihypertensive medication, there's going to be anti-lipid medication, maybe an anti-diabetic medication in those medications as you get older. You know? So yes, so I can't answer them fully, I'm sorry. Okay.
Thank you so much for your questions and answer. So, Dr. Chris? So here's some little speech from Professor Chris.
Thank you very much. Look, I think we'll draw this to an end. It's been a very informative meeting. I'd like to thank the speakers very much for the excellent talks they gave. I'd like to thank the organisers, particularly Toan, Chow, and everybody else who put this session together. Thank you very much for translating. You've done an excellent job, and we're very grateful for that. And we hope to come back again next year and do it again if you'll accept us or if you'll allow us to. So thank you very much for coming, and all the best. Thank you.
Dạ, và xin được trân trọng cảm ơn thầy Phó Giáo sư Christopher Pokomy cũng đã có lời đáp từ cho chương trình hội nghị ngày hôm nay. Kính thưa quý vị đại biểu, thưa quý thầy cô, như vậy thì sau nhiều phiên báo cáo rất là bổ ích thì chúng ta cũng đã khép lại nội dung của buổi hội nghị sáng ngày hôm nay. Xin được gửi lời cảm ơn chân thành nhất đến quý vị đại biểu, quý thầy cô, các thầy cô báo cáo viên cũng như là những vị khách quý đến từ Học Mãi Foundation đã góp mặt sẽ có sự tham dự trong buổi sáng ngày hôm nay.
Thank you so much, Associate Professor Dr. Christopher Pokomy, for your closing speech. And thank you all the guests from Học Mãi Foundation, the delegates, the lecturers has attended today's seminar. So lastly, I want to take a picture of all of us, the people that